Good morning.
Morning,
Good
Stan.
morning. Okay, well, I think we're going to get started this morning. So, good morning. Welcome back to the 37th annual and first ever all virtual annual meeting of the Northeastern Society of Plastic Surgeons. It's my distinct pleasure to welcome all members as well as future members of our society to this meeting this morning. Given the unconventional format of this year's meeting and that many of you here today were not present yesterday, I'm going to briefly touch on a few things again. Although this clearly has been an unconventional year, to say the least, I'm so grateful we're able to come together and celebrate the work of so many accomplished young surgeons and students. Yesterday, by all accounts, was a resounding success. And although the interpersonal physical elements of interacting with each other are still missing in this format, we were still very successful providing a day of outstanding education and discussion. The NESPS was faced with the possibility of canceling this meeting completely. But after receiving over 400 incredibly impressive abstract submissions, myself, Program Chair Suhail Kunswala, the Program Committee, and the NESPS Board of Directors determined we have to find a platform for our future members to present and continue our annual tradition. So I'm thrilled we were able to host this meeting for you this weekend, and even more thrilled that we had such success yesterday. Our Program Chair, Dr. Suhail Kunswala, who I'll turn things over to shortly, and his committee had the unenviable task of reviewing over 400 submitted abstracts, which was a record for our society and almost double from most previous years. I personally read them all, and I could say they were so impressive. We wish we could have extended the day to allow more presentations, but given the platform and the time constraints, opportunities were obviously extremely limited. So we hope that at some point, you'll take the time to review the online portion of the program, which will continue to remain up on our website, nesps.org. On the virtual program portal, you could view the 52 additional virtual podium presentations that cannot be included in today's live program due to time constraints. And please also take some time to rate them using the STAR scoring system, because there'll be an award for the best papers on that program as well. Now, it's important you understand we consider these virtual only papers part of our formal program, despite our inability to include them in the formal program live. I'd like to also take this opportunity to thank our sponsors who generously provided funds for this program and also helped us to hold this for free. And I invite everyone to visit the virtual program portal, which houses the digital marketplace, where you could visit sponsors in real time and chat with them if necessary. So before I pass the reins over to Dr. Conchwala, I just want to, again, thank Suhail and his committee for all their hard work and keeping an open mind as we navigate a new territory. I want to personally thank our moderators who agreed to participate and share their expertise with us this weekend. In addition, the staff at our management company, PRI, should be commended for their incredibly hard work and the massive efforts it took to put this program together for us, especially on such short notice. It was no small task. So on behalf of myself and the NESPS Board of Directors, I want to thank you, and thanks to all the presenters today. I hold out hope that we could look forward to a more normal annual in 2021, and I truly hope to see all of you there with me in Philadelphia next fall in person. Finally, please don't forget to look out for information about our spring workshop in March. This is going to focus on elements of breast surgery. We had an outstanding program in place last year, and all the people and presenters that were scheduled to present have agreed to participate once again, regardless of format. So the day should be an outstanding educational opportunity for everyone. You'll be receiving more information about this in the coming weeks and months. And now I want to introduce our program chair, who's worked incredibly hard and has done a remarkable job. Couldn't have asked for more, Suhail Conchwala. Thank you very much.
Thank you, Brian, and for really honestly for everything you've done to support the society for many years and your leadership here. It's a huge honor for me to have been the program chair for this session. And I think that there's a lot of wonderful things about the Northeastern, and I've been going to this meeting for the better part of the last 20 years. And one of the best things about this society is the level of engagement, the density of talent that we have in the Northeast. And that was clearly evident in the session yesterday, where we had so many great presenters. The moderated sessions were excellent, and we had excellent interaction from all the attendees. I'd like to share a couple housekeeping items before we begin our formal program. And for those of you that weren't here yesterday, this will be some new information to you. At the bottom of your Zoom screen, there's a question and answer chat function. Please use that liberally throughout the presentations as you think of a question or a comment for any of the presenters. This will allow the moderators to more accurately judge the audience in participation and be able to ask your questions during the question and answer session. Also, please, at various breaks throughout our session or at times after the session, please visit the virtual marketplace. Our sponsors are really what allow our society every year to function, even more so in this year when we could use their support even greater. And lastly, it's important for you to realize that the virtual part of the program is just one part of it. We have a second abstract category that we weren't able to present online. Those abstracts are going to be able for viewing for a week or so after this program. And I think the deadline for submitting rankings for those is essentially October 12th. So you have a long period of time to still see the other abstracts. And I urge you to do that in order to honor the effort that those participants also put into this. With that, I'd like to introduce the first session of this morning, which is the hand session, to be moderated by my partner, Inez Lynn, and Jim Higgins.
Thank you, Suhail. Welcome to the hand and extremity section on behalf of Dr. Higgins and myself. The first paper is Impact of Unrepaired Scapholinate Ligament Injury Following Intra-Articular Distal Radius Fractures on Patient Outcomes from Penn and Duke.
Good morning, everyone. My name is Kevin Clifto. Today I'm presenting the impact of unrepaired scapholunate ligament injury following intra-articular distal radius fractures on patient outcomes. The study was done with Penn and Duke. Distal radius fractures are estimated approximately 14% of all extremity injuries. The most common intercarpal ligament injury associated with distal radius fracture is a scapholunate ligament injury, with an incidence of approximately 63%. There's no clear consensus today on how to manage a scapholunate ligament injury in the setting of a distal radius fracture. The purpose of our study was to evaluate a series of intra-articular distal radius fractures to determine if patients without a radiographically evident scapholunate ligament injury have a difference in outcomes in comparison to patients with unrepaired radiographically evident scapholunate ligament injuries. Our hypothesis was that there were no significant differences in long-term outcomes between these patients following treatment. Our study was from 2006-2019. It was a retrospective series of patients that we included had age greater than or equal to 18 years with intra-articular distal radius fractures. They did not undergo concomitant scapholunate ligament repair. They were treated by a hand surgeon with a minimum follow-up of 12 months. They were excluded if they had extra-articular fractures that demonstrate inadequate radiographs at any of the time points, incomplete outcome scores, open fractures, perilunate injuries, fracture dislocations, ipsilateral soft tissue injury or concurrent fractures, and scapholunate angles greater than or equal to 70 degrees prior to injury. SL angles were measured as described by Larson. These were measured on lateral radiographs by first drawing the lunate line perpendicular to the tangent of the two distal poles in the first image. The second scaphoid line was drawn tangent to the palmar proximal and distal margins. You can see in the second image. These angles were measured between the two lines. So radiographic scapholunate ligament injury was determined to be an SL angle greater than or equal to 70 degrees. SL angles or intervals were measured on PA radiographs as the distance between the midpoint and proximal margins of the scaphoid and the lunate carpal bones. An abnormal interval was greater than 2 millimeters. Radiograph parameters were measured at 3 points. The first was baseline in the ipsilateral wrist, if this information was available prior to injury, or contralateral wrist at the time of injury. The second one was following closed reduction or prior to surgical intervention. And the third was at final follow-up, where outcomes were Q-scores measured on a scale of 0 to 100, 100 being greater disability, modified global assessment of function scores, measured on a scale of 0 to 100, with 100 being the least amount of disability. And the visual analog scale pain scores measured 0 to 10, 10 being the most with the greatest pain. These are measured 2 weeks following intervention and final follow-up. For comparisons between SL angles less than 70 degrees versus SL angles greater than or equal to 70 degrees, either at 12 months or 24 months. So at 12 months, we measured outcomes and complications, and at 24 months, we measured outcomes. For demographics, there were no significant differences really between SL angles less than 70 and greater than or equal to 70 degrees for age, sex, hand dominance, side of wrist injury, if they've had surgery, operative treatments, or non-operative treatments. You can see in these comparisons. At 12 months, you can see that at closed reduction and final follow-up in both angles and the intervals, they were significantly greater with angles greater than or equal to 70 degrees. However, for other outcomes, there were no significant differences. In terms of complications, tenosynovitis was significantly higher with SL angles less than 70 degrees. And for our 24-month follow-up, we see similar results. However, at initial follow-up VAS pain scores, there were higher pain scores initially with SL angles greater than or equal to 70 degrees. To summarize, we found no significant differences in patient-reported outcomes between patients with radiographically evident scapholunate ligament treated without repair or reconstruction in patients without radiographically evident scapholinate ligament injury following treatment of an intra-articular distal radius fracture. So this really supports the current thought that the repair of scapholinate ligament injury at the time of a distal radius fracture fixation may not be necessary. Thank you everyone for the opportunity to present this morning.
Next paper 32, wrist pain and functionality in surgical versus conservative management of distal radius fractures in the elderly, a short-term prospective study from the University of Massachusetts.
I'd like to thank you to the Northeastern Society of Plastic Surgeons for the opportunity to speak about wrist pain and functionality in surgical versus conservative management of distal radius fractures in the elderly. We have no disclosures. Distal radius fractures account for 15% of all skeletal fractures. It is a disabling injury that prevents normal activities of daily living and can result in a decreased quality of life. This is particularly the case for elderly patients who are in higher baseline risk for both falls and fractures. There are three major modalities of treatment for this kind of fracture: external fixation, immobilization with casting, and open reduction with internal fixation. Our previous study has demonstrated that internal fixation with a volar bearing plate is both safe and efficacious in the treatment of distal radius fractures in the elderly. In the literature, immobilization with casting and open reduction with internal fixation are the two most commonly performed and have both been shown to have similar long-term outcomes. However, if elderly patients wait a long time to regain functionality, this injury can have a significant impact on their ability to take care of themselves. Our study aims to compare these treatment options to find the one with superior short-term outcomes that may allow a patient a faster return to functionality and better range of motion, as well as a less painful recovery. We hypothesize that the operative management would minimize immobilization and thereby surpass casting during the short-term recovery period. In our study, patients with unilateral distal radius fractures with or without ulnar styloid fractures, 65 or older, from 2017 to 2019 were identified. We excluded patients with additional bony trauma except for unilateral ulnar styloid fractures. Operative patients were treated with a volar bearing plate and began volar orthoplast splinting and range of motion therapy 1 week after surgery. Non-operative patients were casted for a total of 6 weeks, 3 weeks long arm, 3 weeks short arm. We assessed patients at each follow-up on treatment weeks 1, 3, 6, and 12. Our outcome measures include functionality using the Quick Dash survey, range of motion, and patient-reported wrist pain. This is the Quick Dash survey, which scores functionality to accomplish home activities of daily living, with 1 being no difficulty and 5 being unable. This score is a normalized sum, with a greater quantitative number representing increased difficulty in performing everyday functions. A score of 0 represents no difficulty, while 100 represents maximum difficulty. We had 54 patients in the open reduction internal fixation group and 22 in the casting group. The demographics of sex, osteoporosis, diabetes, BMI, prior trauma, and smoking were comparable. The average age of the operative group was 73.4, while the casting group was 74.1. These are the results of our Quick Dash data. The Quick Dash score of 0, again, indicates no difficulty with everyday tasks, whereas the maximum Quick Dash score is 100. We found that the Quick Dash scores trended lower in the surgical group starting at a 3-week follow-up visit, representing a better return to baseline functionality starting by the 3rd week. Our data suggests that the operative management is associated with superior functionality at the 3rd, 6th, and 12th week follow-up visits compared to the conservative group. We also evaluated range of motion and did not find any significant difference in degrees of range of motion for wrist supination, pronation, extension, flexion, radial deviation, ulnar deviation for the first 3 weeks of treatments between the two groups. At the 6-week mark, the surgical group demonstrated statistically significant greater radial deviation as well as ulnar deviation. Extension and flexion were almost statistically different at p is less than 0.06, and supination and pronation also trended higher in the surgical group. At the 12-week mark, flexion and extension are significantly greater. This combined data suggests that by the 6-week mark, patients have a better range of motion if they had received open reduction and internal fixation compared to casting alone. We also assessed the presence of wrist pain at every visit. Patients treated with casting alone reported more pain at week 3 and 6, suggesting better pain recovery for the surgical management group. In conclusion, surgical management by an open reduction internal fixation provides better short-term outcomes than casting and mobilization in the elderly. The surgical group demonstrated a lower Quick Dash score at weeks 3, 6, and 12, suggesting earlier and improved return to baseline functionality, and statistically significant better extension, flexion, radial deviation, and ulnar deviation by week 6, with an uptrend in all categories, indicating better range of motion for the surgical patients. Wrist pain is also less for the surgical group at weeks 3, 6, and 12. These results together show that a surgical intervention of distal radius fractures in the elderly allows for an earlier return of function. Therefore, we believe a thorough discussion of the surgical option is imperative to provide the best treatment for distal radius fractures patients over 65. And going forward, we will continue to recruit patients to further power our study results. I'd like to thank the UMass plastic surgery staff and our residents as well.
Next, paper 33, lower extremity lymphatic function predicted by body mass index, a lymphoscintigraphic study of obesity and lipedema from Boston Children's.
Hello, my name is Chris Suddeth, and thank you very much for the opportunity to present our work studying the effects of body mass index on lower extremity lymphatic function. Disclosures are for the senior author, and there are no conflicts of interest. These are the 3 conditions. Obesity-induced lymphedema or OIL occurs in obese patients with inadequate lymphatic function. Obesity without lymphedema, or OWL, occurs in obese patients with normal lymphatic function. And lipedema is a lipid dystrophy that does not affect the lymphatics. There's often clinical confusion between these 3 conditions because they can appear very similar. So therefore, the purpose of our study was to better delineate these conditions in order to improve their diagnosis and treatment. Our lymphedema-centered database of 700 patients was queried for patients with obesity, that is, a BMI greater than or equal to 30, or lipedema. Patients with primary or secondary lymphedema were excluded, and only patients that had undergone lymphoscintigraphic documentation of their lymphatic function were included. In total, 98 patients met the final inclusion criteria. And in these patients, we found that lymphatic dysfunction was directly related to increased BMI. This figure shows our patient cohort grouped by BMI. At a BMI of less than 40, no patients had lymphatic dysfunction. We started seeing lymphatic dysfunction in patients with a BMI between 40 and 49. In this group, 17% of patients had lymphatic dysfunction. And as you can see, as BMI increased, so did the proportion of patients with lymphatic dysfunction. At a BMI of 50 to 59, 63% had dysfunction, 60 to 69, 86%, 70 to 79, 91%, and a BMI of greater than 80, 100% or all patients had lymphatic dysfunction. These are examples of patients from our cohort. The overgrown leg looks the same regardless of underlying lymphatic function. This is why the only way to definitively diagnose these patients was using lymphoscintigram. However, now, because of the data I showed you on the previous slide, when these patients come into our clinic, we can estimate or predict the chance they might have lymphatic dysfunction based on their BMI. So for example, the first patient, a BMI of 36, we know that no patients less than a BMI of 40 had lymphatic dysfunction. This patient had a normal lymphoscintigram. The next 2 patients, BMI of 45 and 48, patients in this group had a 17% chance of lymphatic dysfunction. The first one has a normal lymphoscintigram, the second has an abnormal lymphoscintigram. And so on and so forth. As BMI increased, we saw that the proportion of patients that had lymphatic dysfunction also increased. Again, lipedema is a lipid dystrophy that does not affect the lymphatics. However, it does predispose patients to obesity. And in these patients, we found that lymphatic dysfunction was also associated with increased BMI. Here are 3 examples: a BMI of 33, normal lymphoscintigram; a BMI of 46, normal lymphoscintigram; a BMI of 54, abnormal lymphoscintigram. So in conclusion, these are 3 related conditions, and they can all cause an overgrown leg. BMI can help us predict the chance that a patient might have lymphatic dysfunction. However, definitive diagnosis requires lymphoscintigram, and it is critical to accurately diagnose these patients because prognosis and treatment differs. For example, OIL patients have 70 times increased risk of infection, and they can develop areas of soft tissue overgrowth in their extremities called massive localized lymphedema, or MLL. Treatment is weight loss, and we often refer our patients to bariatric surgical centers. Obesity without lymphedema, these patients are at a risk of developing lymphedema, and treatment for these patients is weight loss. These patients will rarely require a procedure on their extremities. Patients with lipedema are at risk of becoming both obese and developing lymphedema. Liposuction might be offered to these patients if their BMI is not exceedingly high. The figure on the right shows a cycle that we unfortunately see many of our patients in. For example, a patient with lipedema might come into clinic. This predisposes them to becoming obese. As the patient becomes more obese and their BMI increases, their lymphatics are injured and they develop lymphedema. As their legs become more and more swollen, it becomes more difficult for them to lose weight. They become more obese, thus further injuring their lymphatics, and they go around and around the cycle. So therefore, one of the most important things we do in our clinic is counsel patients to maintain a normal BMI so they can never get caught up in this vicious cycle to begin with. Thank you very much for your time. I'd like to conclude here. Thank you.
Paper 34, should antiplatelet therapy be held perioperatively? The first study examining outcomes in patients receiving dual antiplatelet therapy in the lower extremity flat population.
Hello, my name is Mark Mishu. I'm a fourth-year medical student from Georgetown. Today, I will be presenting a retrospective review looking at dual antiplatelet utilization in the lower extremity flat population. An estimated 120 million adults suffer from cardiovascular disease in the U.S. and are often managed with dual antiplatelet therapy such as aspirin and clopidogrel. In our highly comorbid chronic wound population, an even larger proportion of patients suffer from cardiovascular disease and are prescribed these medications. When these patients undergo a free flap, there is a dilemma on what to do with their antiplatelet medication. Our main goal was to investigate and answer the question, should perioperative dual antiplatelet therapy be held in a patient undergoing a free flap for lower extremity reconstruction? There are theoretical pros and cons to continuing dual antiplatelet therapy in the perioperative time period. Pros, less chance of thrombosis in the flap and no lapse of cardiovascular protection. Cons, increased bleeding, which could cause increased blood transfusion volumes and cause hematoma formation, jeopardizing the flap. This was a single-center retrospective review of patients who underwent free flap for lower extremity wound reconstruction from 2011 to 2019 by a single surgeon. There were 3 groups. First group, no dual antiplatelet therapy in the hospital course. The second group held clopidogrel the day before surgery, and the third group continued dual antiplatelets through surgery. Bleeding outcomes, flap outcomes, and cardiovascular outcomes were analyzed. 196 patients were included. 35 patients were on dual antiplatelets. Clopidogrel was held for 21 and continued for 14. Looking at flap outcomes, specifically at thrombosis, either intraoperative or postoperative, they occurred at 6.1% in free flap patients. When considering intraoperative thrombosis exclusively, the incidence was highest in the held group, but was not statistically significant. Looking at bleeding outcomes on initial testing, the incidence and volume of blood transfusion was significantly higher in the held and continued groups versus the non-dual antiplatelet group. When accounting for confounding factors using multivariate analysis, the perioperative dual antiplatelet group was no longer statistically significant for intraoperative transfusion. For postoperative transfusion, only the held dual antiplatelet group was found to have a significantly increased risk of postoperative transfusion over the non-dual antiplatelet group at an odds ratio of 4.27. When considering hematoma formation, flap hematomas, the incidence was only similar among all 3 groups. The incidence was similar in all 2 groups. However, a statistically significant difference remained for incidence of donor site hematomas, which occurred most frequently in the continued dual antiplatelet group. For cardiovascular outcomes, the overall incidence of adverse perioperative cardiovascular outcomes was low, as shown in Table 4. Cardiac events, which included demand ischemia or myocardial infarction, occurred most often in the continued DAP group at 21.4%, compared to the held dual antiplatelet group at 4.8% and the non-dual antiplatelet group at 0.6%. In summary, it was not statistically significant, but data showed trends that dual antiplatelet could be protective for intra and post-op flap thrombosis. Holding clopidogrel was not associated with decreased intraoperative transfusion. There were increases in volume of blood products transfused with patients on dual antiplatelet therapy, but these increases were explained with confounding variables. There was increased risk of hematoma for continued dual antiplatelet, but this was just at the donor side. The biggest point to be made is that without any major side effects, dual antiplatelet provided continued cardiovascular protection through the perioperative time period. Thus, our conclusion is that dual antiplatelet can be safely continued throughout the operative course to minimize cardiovascular risk. I would like to thank Dr. Taub and the Northeastern Society of Plastic Surgeons for the opportunity to present today. I would also like to thank my mentors on this project, Dr. Evans, Dr. Adinger, and Dr. Tan for their guidance, as well as our chair, Dr. Song, and the Department of Plastic and Reconstructive Surgery for their support. I'm looking forward to answer any questions during the discussion. Thank you.
Next, paper 35, free vascularized fibular physeal transfer for proximal humerus reconstruction in children. And also please enter questions in our chat box. Thank you.
Thank you for the opportunity to present. The authors have no disclosures. Advances in upper extremity osteosarcoma management has prolonged survival. Limb salvage is preferred. However, options for a child with skeletal immaturity are limited. Vascularized bone grafts retain biologic mechanical properties, heal by primary union and hypertrophy. They may lessen infection risk and may be used in defects measuring up to 26 centimeters in length. The free vascularized fibula is the workhorse flap for upper extremity bony reconstruction and was originally described by Ian Taylor. When discussing pediatric proximal humeral reconstruction, 80% of growth is governed by the proximal physis. Free fibula epiphyseal transfer was originally described by Marco Innocenti and more recently reported on by Dr. Erdman, Dr. Shamas, and Dr. Levin. The authors review their multi-institutional experience in pediatric patients using free fibula physeal transfer. Here you can see the markings for the anterior lateral approach, which is used in this technique. A retrospective review from 2004 to 2020 was performed at Duke Chop University of Pennsylvania. Outcomes measured included complications, growth, pain, and final ambulatory status. Surgical technique included resection of the cancer with the proximal glenohumeral joint. Here are the markings for the anterior lateral approach to the fibula harvest. Here is a view of the fibula with the overlying peroneal nerve. Here's the fibula graft with the anterior tibial vascularized pedicle. At this point of the case, we were inserting the fibula into the proximal humeral defect. And finally, we are reapproximating the shoulder joint and overlying capsule. Post-operative radiographs are assessed for osseous union, fractures, and other complications. Axial growth of the transferred bone was calculated, and measurements were performed under the supervision of a pediatric musculoskeletal radiologist with 7 years of clinical experience. 8 patients were included in the study, 5 to 11 years old. All had neoadjuvant chemotherapy. Immediate reconstruction was performed in 7 and delayed in 1. Skeletal fixation included plates in 5 patients, screws in 3, and 2 patients received adjuvant chemotherapy. 1 patient developed chemotherapy-induced cardiomyopathy, necessitating heart transplantation. 2 patients developed lung metastases. However, all were alive at last follow-up, averaging 71 months. 4 patients suffered traumatic fractures. 3 healed with immobilization. 1 required operative fixation. There is 1 case of proximal physeal vascular necrosis, 1 case of proximal head avulsion, and 7 patients suffered peroneal nerve palsy. 3 resolved. All transferred bones survived. Longitudinal growth was confirmed in 5 of 8 cases at about 0.5 centimeter per year. Proximal fibula physis contributed 71% of total growth. There were no cases of infection and no plan for amputation. When discussing longitudinal growth, Marco Innocenti and colleagues reported a growth rate of about 1 centimeter per year. Shamas and colleagues reported about 0.5 centimeter per year. Reasons to explain variability include age relative to skeletal maturity, recipient mechanical humeral factors, quantity of the blood supply, and chemotherapy. Peroneal nerve palsy has been previously reported to occur at a rate of 67 to 100%. This results from skeletonization during dissection. However, most transient palsies will improve within a year. Here you can see the peroneal nerve overlying the fibula prior to harvest. Fractures are common complications and have been reported in 20 to 40% of cases. Recommendations included using non-rigid locking compression plates with unicortical screws and reducing the number of proximal screws. Here you can see the fracture in one of our pediatric patients post-operatively. Overall, free fibula transfer for pediatric proximal humeral reconstruction preserves the potential for bone growth. However, the operation is not without risks. Peroneal nerve palsies and fractures are common. However, patients use their reconstructed limb without pain. Thank you very much for your time.
Okay, we'll go to some questions. Inez, you can hear me, right? Nod your head if you can. Great. I'm James Higgins. I'm co-moderating with Inez here, and these were 5 fantastic papers, all of which we have a multitude of questions about. We only have 5 minutes to cover them, so we'll try and be quick. We'll start in order. Kevin's paper from UPenn regarding the very common question. You're faced with a distal radius fracture that has an increased scapholunate angle. Should you or should you not openly treat this? And this was attacked by comparing retrospectively a large cohort of patients that some had elevated SLs and some did not. And in the end, it appeared that there was no difference in outcome. One of the questions I clearly had was whether or not any of the indications of elevated SL angles actually were confirmed to be scapholunate injuries, because obviously there can be many cases where this is not a scapholunate injury, and we all know that that exists. So I wonder if, Kevin, you could tell us, were any of these addressed openly? Like I saw there were some spanning plates and dorsal plating. Was there any confirmation of scapholunate ligament injury in any of the subset of cases? And were those cases studied?
Hi, sorry, I was trying to unmute myself. So most of them were volar plated, and some of them were confirmed arthroscopically in our patient cohort.
Is there an effort being made to study the ones that were confirmed arthroscopically as a subset? I noticed you didn't elaborate on that.
Yeah, you can tell him that future.
So I also have Rachel here, FaceTimed in. so she's also here with me. Rachel, if you want to take this, or do you want me to take it?
Yeah, can you hear me, Dr. Higgins?
Yes, thank you, Rachel.
Okay, hey, thank you for moderating today's session. There are a couple things that we looked at. So some of them were confirmed, but we wanted to use radiographs mainly to look at potential SL injuries, because a lot of these are not confirmed arthroscopically. And so we wanted to use what we had most readily available. And I think SL angle has been shown to be more predictive of an SL injury over the SL gap or SL interval. And so our thought was that we would look at patients that had not only acute SL injuries, higher grade injuries, but also ones with probably secondary constraint injuries. So more apt to develop, slack or some kind of form of carpal instability. Another thought we had is that just reduction of the distal radius itself lent it to more stability of the carpus. And so that's something we're going to be looking at for a future study, seeing that if actually anatomic reduction and fixation of the radius is enough to decrease that SL angle or interval from the time of closed reduction to fixation. So we definitely have a lot of future studies to go from here. And then the last question, I guess it would be another future study looking at those that we did confirm. Do the SL angles increase over time, or is there more further instability? And I think that's going to have to be something that we show with time, because 14 months is not enough. And we did have an increase in SL angles from 74 to 78, but obviously one of the limitations of that is that can just be inter-observer variability. And so I think time will kind of truly tell.
It was a great study and a great contribution, and we look forward to the future work on that. Just to move on so we can hopefully address some of the other papers, number 32, Garrick's paper from UMass regarding the non-operative versus operative management of elderly distal radius fractures. This has been covered in a lot of prospective randomized trials. This is a prospective non-randomized trials. So I think it reinforces what we already feel in that these patients will do better in the short term and ultimately do equally well in the long term. I think one of the things that's very interesting about this was the pain assessment. And maybe Garrick, you could comment on what were the pain management treatment protocols for operative and non-operative? And was your pain assessment binary or was it a visual analog scale?
I can answer the second question easily. It's definitely the visual analog scale, 1 through 10, kind of traditional. In terms of the pain management protocols, I don't believe there was a set protocol in place for who received more or less in terms of medication or other pain measures. That's definitely something that we will investigate before we decide to write the manuscript.
Fabulous study. We look forward to more on that. Sorry to move along pretty quickly here, but we're running out of time. We're going to go to number 33, which is Chris's study from Children's Hospital in Boston. Could you tell us, it seemed there that clearly your point was that increased BMI leads to increased lymphatic dysfunction. And could you explain for us maybe the mechanism of that? And also tell us, are there any patients that come through the door that don't get lymphatic or lymphoscintigram?
Thank you, Dr. Higgins. In terms of the mechanism, the lymphatic function, it's not definitely known, but one potential theory is that weight injures the lymphatic function. And so as there's decreased return of lymphedema fluid, that the increased inflammation results in further damage to the lymphatic function in that cycle I showed at the very end. In terms of the second question, lymphoscintigram, we do refer essentially any patient with a high suspicion of lymphedema, or if we want to rule out the disease, for lymphoscintigram before final diagnosis and treatment. Thank you.
Thank you. We're already a little bit over here. I just would like to pose one question here to Mark from Georgetown about the incredible database. We've seen a lot of studies come out of that institution that have been really impactful. This database was fascinating. Clearly, the conclusion was a little bit confusing in that, we always wondered whether or not we should stop antiplatelet therapy preoperatively. And it seemed, at least from the outside, that the donor site hematoma group was increased. Donor site hematoma incidence was increased in those who had continued therapy, and the cardiac events were increased in those with continued therapy. That would lead the conventional provider to say, oh, good news, that supports what I do. I usually stop antiplatelet therapy. And yet you concluded that perhaps it was best to continue antiplatelet therapy. Could you just elaborate a little bit on that?
Yeah, due to the scarcity of outcomes of specifically cardiovascular outcomes and even ischemic outcomes, we weren't able to run multivariate analysis on those and account for confounders. We believe that if we were to have more data on this, and that's probably a point that needs to be made, we could run that analysis and account for those confounders. And I think that would explain a lot of the increased cardiovascular negative outcomes in the continued group, because obviously that doesn't make inherent sense. We think there's obviously variables to explain that.
Let's see if anyone's going to answer this difficult question, it's going to be this group, because that database is incredible. And thanks very much for presenting. Just quickly to get to the last paper, this fibular physeal transfer paper, which is an incredible series of 8 cases over 7 years, which backs up some of the previous work of Marco Innocente. These are incredibly hard cases, and you showed a fairly high complication rate, which is not a criticism, it's just honest reporting. In particular, the thing that we all worry about is the peroneal nerve palsy issue with this, and that's the fearsome complication. It was my understanding that in harvesting this, in order to maintain that physeal vascular branch, you would routinely have to purposely transect at least one of the branches of the peroneal nerve to the anterior compartment and then repair it in these young patients. You showed 7 peroneal nerve palsies, and 4 of them appeared to be permanent. You had mentioned in the conclusion that this was due to neurolysis. was it just neurolysis, or is this indeed still, do we still require a purposeful transection of one of the branches?
Hi, Dr. Higgins. I hope you can hear me, and thanks so much for having me this morning. That's exactly right. You know, as I kind of mentioned in the conclusions, this is the only option really that offers growth to these patients, but unfortunately, you're purposefully transecting those nerves to the muscle. Of course, you're trying to, after doing so, you co-opt whatever you can. But even in Innocenti's series, he reported about 2/3 of patients with peroneal nerve palsies. So it's definitely a significant complication, something to be aware of. But when you're basing it off of the anterior tibial artery neurovascular pedicle, there's very little that can be done aside from a meticulous dissection and repairing those nerves.
Well, it's a great series, and I was so happy to see it. Look forward to seeing it in its full written form to read all the details, because there's a million questions I could ask you. But in summary, and I'm sorry we ran over a little bit, I don't want to encroach on the next group. We have 5 fantastic abstracts, and we applaud the authors for their efforts.
Thank you.
Great. Thanks, Jim and Inez, and for all the presenters for a wonderful hand session. The next session coming right up is the craniofacial session, to be moderated by Joe Losi and Jesse Taylor.
All right, and now for something completely different. We'll move on to session 6, craniofacial surgery. And on behalf of Joe Losi, I'm Jesse Taylor. Thanks for joining us. We'll move straight into abstract 36, mandibular subcondylar fracture, improved functional outcomes in selected patients with open treatment, from Northwell.
Thank you for the opportunity to present today. We have no financial disclosures. Subcondylar fractures are a very common mandibular fracture, with some papers quoting as high as 30% of all mandibular fractures. But whether to open or close treat these patients remains controversial. The indications for open treatment of these subcondylar fractures largely comes from a sentinel paper by Zide and Kent, which is now almost 40 years old. We sought to add to the growing body of literature and compare open and closed treatment of low subcondylar fractures. In order to do this, we performed prospective analysis of consecutive subcondylar fracture patients from 2013 to 2018. Patients were included if they had unilateral, significantly displaced subcondylar fractures. This meant they had greater than 15 degrees of angulation or more than 3 millimeters of ramal shortening. They were then assigned to either closed or open treatment arms based on the month of their consult. All patients included also had greater than 6 months of follow-up. Patients in the open treatment group received a risen incision in order to access the subcondylar fracture. Visualization was assisted with an angled endoscope, and the fracture was fixated with a 2.0 titanium plate with the assistance of a right angle drill and a right angle screwdriver. Patients that received closed treatment were treated with 2 weeks of MMF in wires, 2 weeks of tight elastics, and 2 weeks of loose elastics. We then compared the open and closed treatments with symptoms related to TMJ, as well as function of their mouth opening. All patients also completed the face Q. When looking at the demographics of the two groups, they're very similar except for OR time, which, as expected, the open treatment was longer by about 20 minutes. When looking at the post-operative TMJ symptomatology, open treatment had a significantly less amount of symptoms, with less than 10% of open treatment patients. These symptoms included unilateral pain, unilateral headache, or TMJ tenderness or pain. When looking at post-operative maximal mouth opening, patients treated with the open treatment also had a significantly greater mouth opening. Additionally, on the functional score as evaluated by the surgeon, the patients with open treatment did significantly better, as you can see here in this graph. When looking at the results of the face Q and how the patient self-evaluated them to be functioning, open treatment patients did better on social function, their psychological well-being, their early life impact, satisfaction with outcome, and satisfaction with decision. These results show that open treatment patients had lower TMJ symptomatology and increased mouth opening for better overall mouth function. These patients also self-reported that they were more satisfied after open treatment. In conclusion, these results seem to suggest that open treatment yielded better long-term outcomes in this specific patient population. Future avenues of study can expand on these inclusion criteria and include higher subcondylar fractures and possibly even bilateral. Thank you.
Thanks, Kevin. We'll move on to the second paper in this session entitled Primary Cleft Rhinoplasty, Long-Term Outcomes of a Single Technique Used Over 2 Decades, presented by Matthew Wright.
Good morning, my name is Matthew Wright. I'm a PGY1 at New York Presbyterian Hospital. In recent decades, primary cleft rhinoplasty has become a gold standard in cleft lip repair. There are multiple benefits to primary rhinoplasty, including improved outcomes and reduction in nasal revision procedures, less complexity upon secondary rhinoplasty if needed, improved psychosocial benefits, and the benefits of nasal correction if unable to return at a later age. A variety of techniques exist, but few have been studied sufficiently to provide follow-up into the patient's adolescent years. Therefore, the purpose of this study was to assess short and long-term outcomes following a single surgeon's utilization of a modified Salyer technique for primary cleft rhinoplasty. Our study extended from January of 1996 through to January of 2018. We identified patients by the relevant ICD-9 and 10 codes. Inclusion criteria, patients with primary cleft rhinoplasty via the modified Salyer technique. And exclusion criteria included patients undergoing revisionary procedures, patients greater than 3 years of age at the time of surgery, and any bilateral clefts. Technique used in our series is based on that described by Dr. Kenneth Salyer in 1986 in PRS. The principles of his method include ignoring the abnormal skeletal base and focusing instead on the soft tissues. The modified technique used in our series begins with the markings of a rotation advancement lip repair. After release of the orbicularis oris, the medial and lateral crura on the cleft side are then undermined and released by narrow tip scissors via the existing lip incisions. No additional incisions, including intranasally, are made. The undermining occurs along the anterior and posterior aspects of the lower lateral cartilage on the cleft side, or on a small portion of soft tissue on the underside of the dome that's left attached to preserve vascularity to the cartilage. Of note, no primary septal work is performed. Bases of the medial and lateral crura are then brought together and lip repair performed. Following the lip repair, the now released cleft side lower lateral cartilage is repositioned into a configuration that's symmetric with the cleft side, and then a red rubber catheter is sutured into the cleft side nostril to maintain the released lower lateral cartilage in its new position. A total of 56 patients met the inclusion criteria with an average age of 4 months at the time of surgery. 23% of patients in this cohort had some sort of comorbidity, with the majority of these being cardiac in nature. Here's a breakdown of cleft type. Majority were left-sided and 57% of them were complete. Median follow-up time was 7.5 years. 12 patients required minor long-term lip revision, but no school-age patients required additional correction of the nasal deformity prior to beginning school. 15 patients had follow-up at age 15 years or beyond, and 5 of these ultimately required definitive rhinoplasty as adolescents, and that's 9% of the entire cohort, or a third of the patients with follow-up at age 15 years or beyond. For the remaining 10 of these patients, none were seeking additional rhinoplasty at the time of last follow-up. Regarding qualitative outcomes, the senior author has had excellent results. These images show an infant with left cleft lip repair and primary rhinoplasty at the time of surgery, and then here at 3 months post-operatively. And then here at 8 years out, we see an excellent outcome, and this boy required no additional rhinoplasties. Of note, the vermilion bulge you see here was excised a few years later with a good result. Here's another example, again, a patient with left cleft lip time of surgery, and then at 8 months post-operatively. And here at 17 years old, we see another excellent result with good symmetry, and this patient required no additional rhinoplasty. In conclusion, the cleft rhinoplasty technique outlined in this study results in no additional skin incisions. It's performed at the time of the initial cleft lip repair, and it's yielded excellent results, excellent long-term results. Limitations to our study include the subjective nature of outcomes assessments and the single surgeon, single center nature of the study. However, our review is one of the longest running cleft rhinoplasty series in the literature. And the senior author has not needed to perform elementary school age rhinoplasties on any patients, with the majority of patients with follow-up at age 15 years or greater not requiring a definitive rhinoplasty in adolescence. Thank you.
Thanks, Matt. The next paper in this session is entitled Proof of Concept for a Novel Technique for Autologous Microtia Repair. It's going to be presented by Dr. Barone from Hopkins.
Thank you. These are my disclosures. I'm the co-inventor of the Horizon and Dimension devices that are discussed in this presentation. The auricle is a complex structure, and its deformity leads to both a physical and a psychological burden for these patients. None of the current reconstructive options is ideal. While autologous tissue allows to replace like with like, it has a donor side morbidity, it's a staged procedure, it's pretty lengthy, and most importantly, is extremely challenging even in the hands of expert plastic surgeons. Conversely, alloplastic implants have the advantage of requiring one stage only and having no donor side morbidity, but are burdened by the steep learning curve and high extrusion and infection rates, often requiring removal and alternative reconstructive options. When done by experts, autologous repair leads to excellent results. Now, the problem is that not everyone was born a sculptor and is capable of achieving such high quality results, leading to production of frameworks like these and ending in clinical results that look like this. So in our opinion, the ideal ear reconstruction technique would entail a short duration, high reproducibility, have standardized quality, be done in a limited number of procedures, and high patient satisfaction. With this in mind, we developed the Horizon device family. Let me walk you through the concept before I go on and show you the technique. The ribs are harvested from the child, sliced with the Dimension device, then passed through our shape cutter, Horizon, and the single subunits are then assembled to reproduce the final framework. It all starts with the harvest of rib cartilage. While prior techniques need 4 ribs, only 2.5 ribs are used in our technique. First, the hinged cum plate of the Dimension device is opened, and the full thickness cartilage from the 6th and 7th ribs are placed on the metal platform. The desired cartilage thickness is obtained by turning a knob that moves the base platform on a vertical plane, and the handle is then pushed forward, allowing the blade to slide over the rails and accurately cut the cartilage. The amount of cartilage available for use has now doubled and can be shaped using the Horizon device. The bottom tray clearly indicates the exact location in which the blade will land, while the cutting tray on top holds the blade that will determine the precise shape and size of the different subunits. The base is produced first using the synchondroses between ribs 6 and 7. The handle is then lowered, driving the blades down through the cartilage, producing an extremely precise anatomic subunit. After the cut, cartilage delivery is facilitated by retrieval holes in the cutting tray. And these steps are repeated for the different subunits, namely the tragus and the antihelix. And of note, the antihelix is produced from the full thickness 8th rib cartilage in order to obtain good projection of the antihelix. The remaining sliced piece of the 6th and 7th synchondroses is then separated, and the caudal portion of the 7th rib cartilage is thinned further to better achieve contour of the caudal aspect of the helix. It is then wrapped around and wired to the base subunit to create the helix. Finally, the block remaining from the production of the tragus is cut in order to provide a posterior pedestal for the framework and obtain ear projection. And another block of cartilage obtained from the remaining thinned either 6th or 7th rib is used to provide projection of the construct superiorly. Additional patient-specific tailoring can be performed if needed. All subunits are assembled and the final results are shown, front and back. Now, we do understand that tissue coverage is also another limiting step of the procedure. That is why we believe that autologous techniques should be combined with Rhinish's concept of using the TPF flap to provide one-stage coverage. This, in fact, will allow proper coverage and vascularization of the autologous construct. Skin grafts will be then used for final coverage, all in one single stage. In conclusion, our cartilage-sparing single-stage technique is highly reproducible, allows immediate ear projection, limits donor site morbidity, and we expect can be adequately covered by a TPF flap and skin grafts. Thank you.
Thanks, Angelo. The 39th paper, which is the fourth paper in this session, is evaluating the effects of enhanced recovery pathways in craniosynostosis, national trends in hospitalization charges versus length of stay in craniosynostosis surgery.
Hello, my name is Shannon Wu, and I'm a medical student at Case Western Reserve University. Today, I'll be talking about my research evaluating the effects of enhanced recovery pathways in craniosynostosis, specifically national trends in hospitalization charges versus length of stay in craniosynostosis surgery. I have no disclosures. Craniosynostosis is a common craniofacial anomaly affecting 1 in 2,500 live births. There's been a rise in cumulative prevalence due to genetic and environmental factors. The definitive treatment is skull surgery, but it is resource intensive and complex. Enhanced recovery after surgery, or ERAS pathways, are multimodal approaches aimed at minimizing post-operative surgical stress and reducing hospitalization time. ERAS has been broadly and increasingly implemented in hospitals across the country. Early reports have shown ERAS to reduce the length of stay for commonly performed pediatric surgeries such as pyeloplasty, appendectomy, and bowel anastomosis. However, length of stay and hospital charges following craniosynostosis surgery using ERAS has not been studied. Our study analyzes the factors influencing hospital charges relating to craniosynostosis skull procedures and their trends over a multi-year time frame. We chose to use the National Inpatient Sample, or NIS, because it is the largest all-payer inpatient data set in the U.S. It has over 7 million hospital stays in the U.S. each year, and when weighted, can be used to estimate over 35 million hospitalizations annually. We can look at the NIS because it has the demographic data, hospital characteristics, and total hospital charges in it. We collected hospitalizations that met our criteria from January 2009 to December 2014 using diagnosis and procedure codes. And then we analyzed yearly trends. We used the Consumer Price Index published by the Bureau of Labor Statistics to adjust hospital charges for inflation in order to isolate the true changes in hospital costs. Nationally, over 54,000 patients were diagnosed with craniosynostosis over this 6-year time period. We excluded those who did not undergo a skull procedure, and we ended up with over 22,000 patients that we then studied. The average hospital charge for a skull procedure, adjusted for inflation, was over $81,000. However, there is a large variability in the cost observed. The average length of stay for this procedure was 3.8 days with a standard deviation of 5 days. And the average age for a patient getting this procedure was 1 year old with a standard deviation of 10.9, signifying the positive skew in this patient population. Our results showed that for craniosynostosis skull procedures, hospital charges, as shown in red, increased significantly by year, despite a constant length of stay shown in blue. And this warrants further investigation into cost-reducing strategies. Our analysis of the National Inpatient Sample also showed the charges by geographic region. Charges were higher in the West, with the Midwest having the second highest cost. However, these differences were not statistically significant. We next looked at procedures performed by hospital type. We found that urban teaching hospitals performed the most number of craniosynostosis procedures. Furthermore, we found that more patients eligible for skull procedures ended up having these surgeries with time. And there was no marked relationship between hospital volume and charge. In the study, we conclude that the overall demand of skull surgery is increasing in patients diagnosed with craniosynostosis. Hospital charges are increasing significantly despite constant length of stay. And while ERAS has reduced length of stay for other common performed pediatric surgeries, there has been no decrease in craniosynostosis observed. Our findings show a discrepancy with the literature that ERAS can reduce length of stay for pediatric surgeries. The overall healthcare burden of these skull procedures are expected to rise, and our future directions will be to study what may be driving the difference in these hospital charges. A limitation of this cross-sectional analysis is that we were unable to analyze costs beyond individual hospitalization episodes. We were also unable to establish causality between the variables observed. In conclusion, I would like to thank my mentor, Dr. Anand Kumar, and my colleagues Yida and Samuel for their help with and guidance in this project. If you have any questions, please feel free to contact me at the email listed here. I thank you for your attention.
Thank you, Shannon. The final paper in this session is entitled Racial Disparities in Early Evaluation and Management of Patients with Non-Syndromic Craniosynostosis from Pitt.
Hello, my name is Casey and I'm a fourth-year medical student at the University of Pittsburgh. I've been working with the Pediatric Plastic Surgery Lab, and my project focuses on the evaluation and management of patients with potential craniosynostosis. I don't have any disclosures to speak of. So as an introduction, craniosynostosis is a sporadic mutation affecting a little less than 1 in every 1,000 live births here in the US, with the syndromic forms of the condition being much rarer. Historically, studies have shown that white infants are more likely to present with craniosynostosis than any other racial group, and we'll continue to talk about why that's important. For background on craniosynostosis and evaluation, CT imaging has traditionally been used as a routine part of diagnosis, especially for more subtle cases, looking for other abnormalities, determining severity, and planning for surgery. So this is one of the data points we chose to focus on and we'll be discussing as well. For more background, there has been recent research into racial disparities in outcomes for non-white patients being treated with craniosynostosis. And most of the studies have shown that there is an element of morbidity associated with the care of Black and Hispanic patients. They have longer operations, increased rates of readmission, all at older ages. One study suggested that the reason for this delay in care is due to delays in early health-seeking behaviors, but their study controlled for parental education, insurance type, and household income, which I would argue suggests that the only socioeconomic factor playing a role here was race, and further studies are needed to understand more about why this disparity exists. With all that said, the purpose of this study is to understand more about the role of diagnostic imaging in the process of patient evaluation and diagnosis, and where exactly providers can intervene and assist patients in reaching timely surgical intervention. We hypothesize that Black and African American patients are diagnosed and treated at older ages compared to their white counterparts. We used a database of patients seen at the University of Pittsburgh Medical Center's Children's Hospital and went back to analyze the autonomy of their CT scans and their surgeries broken down by race. Patients were seen by multiple surgeons with a total of 277 patients being evaluated. The total number of patients who met inclusion criteria were 246. You can see that 151 of those patients were white, with 95 being Black. 197 of those patients went on to receive a head CT, with 67% of the patients being female. And an even smaller number, 79 patients, were determined to need surgical intervention. Notably, Black patients had a lower overall rate of surgical intervention. Our final results showed that there was a statistically significant difference only in the ages at which these two groups of patients received CT scans. White patients had an average age at CT of 2.3 years old, while Black patients had an average age of 3.9 years old. For patients that went on to need surgery, their ages at CT and surgery were not significantly different, but Black patients still received surgery at older ages on average. So conclusions, white patients are more likely to receive CT imaging and surgery, all at younger ages than Black patients. And while there was no statistically significant difference found in CT imaging for patients that went on to receive surgery, there is likely to be a statistically significant difference found within a larger patient population. So that's definitely something we need to look closer at. The time to surgery in days for these patients was not significant, but still something we wanted to include. I think it's an important data point that we have the time at the initial CT scan and how quickly we can get them to surgery. So this study was important because it did identify a high-risk group. It identified racial disparities for this group of patients. And it's going to be important to identify exactly why these patients are experiencing delayed diagnosis other than just attributing it to patient behavior. We have to recognize that racism, not race, is a risk factor for delayed diagnosis and lower rates of imaging and intervention. That's going to be our first step in determining how we can better intervene on the problem. For future directions, I think it's going to be important to look at severity of presenting symptoms for these patients, what other comorbidities and long-term outcomes they have, and how these patients are getting referred, how they make it to the specialist, and if primary care and looking at pediatrics, pediatricians is going to be something that we need to look closer at. So I want to say thank you to all of my research mentors, Dr. Goldstein, one of the residents, Dr. Onstadt, for their help and mentoring, and all of the Pitt Plastic Surgery family. I've had a great experience there. And I'm happy to answer any questions.
Thank you, Casey. Joe Losi will now lead the question and answer session for this segment of papers.
Good morning, everybody, and thank you very much for your presentations. We have a little bit of time, and we'll quickly go through each of the papers, and there are a couple questions in the chat box that I'll try to incorporate. So let's look at paper 36, number 1. Kevin, you know, not all subcondylar fractures are the same, as you mentioned. And certainly a high subcondylar or head fracture is treated differently than a very low subcondylar. So I was wondering how you really, you know, sorted out the apples and the oranges, how it was decided how you did that. And then the second part is on your treatment arm, how did you decide on 2 weeks of MMF? Did everybody get 2 weeks, and did everybody get an exact same physiotherapy session afterwards? Because I think those are some confounding variables. And then finally, quickly, were there any marginal mandibular nerve injuries in your open group? And a comment in the box was that the true disability from these are long-term TMJ issues, and will those be looked at moving forward? And so thank you.
Absolutely. Thanks for the questions. That was a lot, but I'll try to address them one by one. I think the first question was about how we decided what determined a low subcondylar fracture was. If it was high on the neck, then it was very obvious. It was obviously those mid-neck to lower ones that were more of a judgment call. And that was just done by the senior surgeon that felt that they could adequately access and do a good job even with the endoscope assisting and getting the right angle screw and screwdriver up there. In terms of the MMF treatment, everyone got the same amount of MMF treatment. There was various amounts of compliance with doing therapy afterwards, so that part was less standardized. Obviously, the long-term effects of TMJ is one of the lesser studied parts of all pericondylar fractures and pathology. So we'd love to follow these patients more long-term and continue to follow this patient cohort, but even from 0 to 6 months, we had some loss of patients, and it's not the most compliant set of patients. So we'll see how many continue to stay in the cohort.
Any marginal nerve injuries?
No, there were no marginal mandibular nerve injuries.
Great. Okay, thank you. Let's move on to the next, number 37, Matthew. This is a tough study because it's a cleft study, and we all know that there's really no good cleft study. So I'm just going to ask the tough question. I mean, the need for secondary surgery is such a challenging thing, because, I mean, we could talk about that for days. So, you know, I'm going to think that's a great outcome, you know, awesome outcome. And the mother looks at you like, you know, what planet are you living on? And the kid, letting them decide what they think is good, you know, so, and then when you try to objectively look at it, you showed us 2 kids that really didn't need anything. You know, their primary deformity was the least you could ever get, and showed them older. And I would argue they were still pretty asymmetric when they were older. So not trying to be critical of you, but of Cleft research, quote unquote. How do you tell us that, wow, this technique is great just because the kids didn't want to have rhinoplasty surgery at the end? Sorry for the tough question, but.
No, thanks, Dr. Losey. Yeah, 100%. That's the primary limitation of this study. I think one of the tricks in trying to report long-term outcomes is that 20 years ago we weren't really necessarily thinking about like photometric analysis at that point, so we weren't getting really rigorous pre-op and post-op photos from all different angles. I think sort of this the idea of photometric analysis and analyzing the angles of the repair, sort of the way to go in the long term, and that's something that as a resident has informed my practice. All of my patients, regardless of what specialty I go into, I think getting really rigorous, sort of objective, standardized photos throughout the entire process, pre-op throughout to the long post-op visits is going to be key, just for seeing how my results are, but also in terms of research, regardless of specialty. That I think is the challenge here, is that we don't have all of those photos from 20 years ago, and so that's why we can't really do a great objective analysis of all of these patients' outcomes.
Yeah, I'm sorry again. I just want to make it really clear. I'm not criticizing
No.
or your group. It's just Cleft research is so tough. Let's move on to the next one. Angelo, good to see you. Here's my question. It's a great, I just did one of these the other day. I used the Stryker little template, and I thought, wow, what an advance. I don't have to get X-ray tracing paper, which doesn't exist anymore. But what I find is challenging is once you get the piece of rib out, and I don't care how big the kid is or how small the kid is, it's never standardized. So now you're taking this, if you're using a bar of soap, your machine's going to cut it just, perfectly for you. But when you get a piece of cartilage that doesn't fit the mold, what do you do then?
So we think that the ability to slice the cartilage and duplicate the cartilage really makes a big difference, because you basically go from having a piece of cartilage that could be too small to actually having so much cartilage that even if it doesn't fit exactly the shape on the base plate, you can put different pieces one next to the other, making sure that it's on the shape at the base of the base tray, and then lower the press, making sure that the blade is going to cut both units, and then you can wire those two units.
Okay.
So you can basically use as many pieces as you want, and then you just put them together.
That's awesome, and I can't wait to see it. Do you think that you could use freeze-dried cartilage to do this?
We actually did use it. We're lucky enough to have a company give us 3 tiny pieces of cartilage. We're also investigating what is the youngest age that we could do autologous microtia in. And they actually gave us some allogeneic 3 pieces of 2 centimeter by 1 centimeter pieces. And we were able to build a construct with that. And we thought that was very, very good, because we could potentially do allogeneic reconstruction just with like 3 tiny pieces.
Really interesting. Oh, thank you. Okay, moving right on to the next paper, Shannon. So we understand what ERIS protocols are. They're really important, and we've tried to employ them for cleft palate surgery. But help me understand. An ERIS protocol is you take this protocol, I'm going to standardize what I do, this, and then you look afterwards how it affected your outcomes. It seems like your study, even though it says evaluating the effects of a hand, it seems like your study basically just looked at this big database of hospital charges and length of stay over time. But there was no implementation of an ERIS protocol. So help me understand the title as to what data you got.
Yeah, that's a good point. I would say because it was looking at the national inpatient sample, we're looking at all the hospitals across the country over 7 years, and as opposed to a single institution where you could actually see the hospital's protocols. So we weren't actually able to see ERAS information through the NIS. So I agree with you that what we initially set out to do with the title wasn't really accomplished with the actual results. But I would say that based on data that we've seen, hospitals have been increasingly using ERAS for pediatric surgeries. And just given that trend, we kind of made the assumption that ERAS was being attempted to be implemented. But I would say that if we were to look specifically at ERAS in neurological pediatric surgery, we would have to look at single institution data.
Great, thank you very much. The last paper is from our institution, so I'm going to just ask if Jesse has a question. I don't see any other in the chat box, and I'll make one comment on the last paper. I'm not an author, but I'll just say for craniofacial surgeons, you know, if we're always looking for our next case. And if anything, we've been accused over time of operating on maybe too many minor cases. So I think we are always aggressive at trying to recruit patients for our ORs. So with that I don't know if there's any other questions for
Casey,
them.
I'll chime in with a question or two, and I really want to congratulate you and Dr. Goldstein and your group on a really nice study. I thought the one interesting thing was the demographics of your patient population. I'm not sure what the exact racial composition of the United States is, but the fact that 40% of your patients are ethnically or self-identify as Black seems high to me. Is that typical of who presents to the Children's Hospital in Pittsburgh?
I'm not sure what the exact demographic makeup for like the Pittsburgh area is, but as far as the database, we did try to take all of the patients that identified, and we should probably look at whether they self-identified or whether it was somebody that identified them as Black. And I think it's also important to look at whether, you know, they were mixed Black, whether they identify as someone else in the African diaspora as far as Caribbean or first generation African. So I don't have a great answer for that.
We looked at this question at CHOP several years ago and similarly found that there were racial disparities in our craniosynostosis patients. And one interesting thing we found was that not only did our patients present later, but they also had post-operatively an increased number of trips to the emergency room, which was hard for us to explain. Any thoughts on why that might have been?
Yeah, I think there are a lot of socioeconomic factors that can be contributing to that as far as access to healthcare or patient education. I think answering this question is really tough. You know, untangling centuries of systematic racism is going to be a tough question to answer. And I think there are a lot of effects. So again, I don't really have a great answer, but I think bringing awareness to the problem is going to help us solve it.
Great.
I agree, and thank you for a great paper session. Thanks to Joe Losi and to all the organizers of the Northeastern. I think we should probably move on, and for the sake of trying to not be contributing to being a little bit behind schedule. So thanks to everybody.
Thank you all. That was a great session.
Well, thanks, Jesse and Joe. That was a wonderful session. I really appreciate the engagement that you had with the audience, and the participation of all the presenters was absolutely amazing. The next session, to be moderated by Babak Marara and Jessica Urban-Sager, is the research section.
Great. Good morning. Jessica, are you here? Okay, well.
Good morning. Hi, sorry.
Hi, Jessica.
Yeah, hi. Let's see, sorry.
All right. So abstract number 41 is the effect of vibration on pain during intravenous injection of propofol, a randomized controlled single-blinded study.
Good morning. I will be presenting the effect of vibration on pain during intravenous injection of propofol, a randomized controlled single-blinded study. I have no financial disclosures or conflicts of interest. The purpose of this investigation is to evaluate the role of vibration in reducing the discomfort associated with painful stimulation during anesthesia induction. Propofol is the most commonly used intravenous anesthetic agent. Its ability to provide a smooth induction and rapid recovery are significant advantages that have contributed to its widespread use. However, one of its significant drawbacks is pain on injection. Numerous studies have previously examined the use of medications in the reduction of pain with propofol infusion with varying degrees of efficacy. But to our knowledge, the analgesic effect of vibration on pain with propofol infusion has not previously been investigated. Therefore, we conducted a randomized, single-blinded controlled trial to explore this potential treatment modality. The Palsy device is a small vibrating device developed in 2009 by a fellow physician, is registered as an FDA Class 1 device marketed to reduce the discomfort during venipuncture and intramuscular injections, and it costs around $50 for a single device. After approval was obtained from the Institutional Review Board and the Food and Drug Administration Clinical Trials Registry, a prospective, randomized, single-blinded study was performed on 100 patients who received a propofol infusion during induction of general anesthesia at the ambulatory surgical center. Consenting patients were randomized into 2 study arms with 50 participants in either the control group or the treatment group. The control group consisted of patients who received infusion of propofol without vibration analgesia. The treatment group consisted of patients who received infusion of propofol with vibration provided by the Palsy device. In the treatment group, the Palsy device was turned on and placed on the skin just proximal to the intravenous catheter site by the same research assistant immediately before and during the propofol infusion. The amount of pain perceived by the patients was analyzed by an established 4-point pain manifestation scale described by McCririck and Hunter in 1990 and was scored by 2 independent blinded observers. Furthermore, the location of injection site, gauge of needle, and doses of medications administered during induction were compared. Regardless if the study participant was randomized into the treatment group or the control group, the device was turned on in the operating room, and the injection site was covered in all cases to maintain blindness of the 2 observers evaluating the pain response. Age, sex, and BMI did not differ significantly between the 2 groups, nor were found to be confounding factors in the pain score evaluation. The median summative pain score on a scale between 1 to 6 in the treatment group was 1, as compared to 2 in the control group with the p-value less than 0.01. Participants that experienced any pain were more likely to have had an IV placed in the hand, and the association between propofol dose and severity of pain was weakly positive and was not statistically significant. Neither the size of the needle or the administration of either midazolam or lidocaine during induction were found to be confounding factors in the study. There was no statistically significant difference in the dosages of these medications either. A significantly lower incidence of pain was observed in the treatment group as compared to the control group. 9 patients in the treatment group had pain during propofol injection as compared to 19 patients in the control group. Significantly lower severity of pain was found in the treatment group as compared to the control group as well. Of note, agreement between the 2 blinded observers regarding pain scores was excellent, with the kappa value equal to 0.82. The presence of any pain during propofol injection was regressed on treatment group while adjusting for IV location. Participants in the treatment group were 0.44 times less likely to be in pain than those without treatment during propofol injection, and this association was statistically significant. Patients with an IV placed in the hand were also 2.7 times more likely to be in pain than those with an IV placed in the forearm, antecubital fossa, or wrist, and this association was also significant. Vibration analgesia has been shown to be an effective pain reduction modality. Our study strengths include treatment randomization with control and high inter-rater reliability. There were no complications in the study, demonstrating the safety of vibration in addition to its efficacy. A limitation of the study is a single-blinded design. However, it was not possible to blind the patient given the nature of the vibration intervention. Although not explicitly validated, we favored using this 4-point pain manifestation scale because of its clearly stated scoring parameters and its repeated use in injection-related pain studies. It was also chosen over alternatives like the visual analog scale due to its objective parameters. In conclusion, this is the first clinical trial demonstrating the efficacy of vibration analgesia in reducing the incidence and severity of painful propofol infusion. Vibration is a low-risk, reusable, and low-cost modality, and it should be considered as an adjunct during induction of general anesthesia using propofol. I would like to thank the Montefiore Department of Anesthesiology and my mentor, Dr. Arvind Pathula. Thank you.
Thank you very much. The next abstract is number 42, adenovirus E4 positive endothelial cells improve volume retention of transplant.
Hi, my name is Ashani Premaratne, and I will be presenting adenovirus E4 endothelial cell assisted fat transplantation improves fat engraftment. Autologous fat transplantation has found many possible applications in plastic surgery, including post-mastectomy deformity, nipple reconstruction, tuberous breast and macromastia, and even gluteal and lip augmentation. However, autologous fat transplantation is frequently plagued by unpredictable degrees of volume loss that can vary from 20 to 90% at 12 months. The inability of transplanted fat to garner a sufficient blood supply has been cited as a key factor that leads to this volume loss. To date, researchers have studied various means of enriching these transplants, including the addition of insulin, vascular endothelial growth factor, and CAL, or cell-assisted lipotransfer, or the co-transplantation of adipose tissue with stromal vascular fraction, which includes adipose-derived stem cells. Still, none of these methods has proved reliable in improving fat graft viability over time. We thus hypothesized that bolstering the angiogenic response of transplanted fat could serve as a powerful means of addressing this problem. To do that, we turned to E4-enriched endothelial cells. These are human endothelial cells that have been transduced with a specific region of human adenovirus type 5. It then became possible for us to think about applying the power of these cells to our problem of fat engraftment. The purpose of our study was therefore to ascertain the potential of fat grafts enriched with E4 cells to demonstrate improved volume retention in a mouse model. To do this, we utilized 3 experimental groups. First, we had a high 80 E4 concentration group. Second, fat grafts enriched with a comparatively lower concentration of E4 cells. And finally, a control group admixed with PBS or phosphate buffered saline alone. We utilized 9 nude mice, 3 per group. 500 microliter fat grafts were then prepared by admixing 100 microliters of either E4 cell suspension or PBS with 400 microliters of processed patient lipoaspirate. Each graft was slowly injected in retrograde fashion with a 1 cc syringe into the bilateral subcutaneous dorsa, such that each mouse received 2 identical 500 microliter grafts. After 180 days, the grafts were explanted, and volumetric analysis was conducted using micro-CT imaging, which allowed us to digitally reconstruct the images and calculate the percent volume retained over time. Hemotoxin and e-insulin staining was also conducted to verify the presence of healthy fat. The percent volume preservation was calculated for each of our groups. First, fat grafts enriched with a high concentration of E4 cells, a second group of fat grafts enriched with a low concentration, and then our control group of fat grafts admixed with PBS alone. Interestingly, the greatest overall volume retention was seen in the fat grafts enriched with a lower concentration of E4 cells at 59.1% compared to our higher concentration. Both E4 enriched groups had greater volume retention at 180 days compared to our control group. Volume retention was also significantly higher in the low E4 concentration group compared to the control group. So what can we learn? From this study, we can conclude that 80 E4 endothelial cell enriched fat grafts demonstrate greater volume retention at 6 months compared to fat alone. The observation that greater volume retention was seen in the lower concentration group suggests that there may be an optimal concentration at which angiogenic properties are maximized, considering the surface area and the density of our implanted grafts. While further studies are certainly warranted, we believe these data represent a promising off-the-shelf therapy for improving the volume and consistency of fat engraftment. Thank you so much to my mentor, Dr. Jason Spector, and my colleagues in the lab. Thanks for your time.
The next abstract, number 43, collagen matrix scaffold functionalization stimulates viability and pro-angiogenic capability of human-induced pluripotent stem cell-derived vascular.
Hello, my name is Kai, and I will be presenting my research on collagen scaffold functionalization stimulates viability and pro-angiogenic capability of iPSC smooth muscle cells. The inspiration for the project came from the prevalence and the difficulties of non-healing diabetic foot ulcers and the limitation of current treatments. This inflicts a tremendous economic and other intangible burdens on both the patient and society. The pathophysiology of wound healing is multifactorial. It involves highly regulated pathways such as inflammation, angiogenesis, cellular migration, and matrix synthesis. In our lab, we are interested in treating those difficult wounds by modulating those pathways using cellular therapy. The approach that we took is utilizing iPSC vascular smooth muscle cells, as it has recently been shown for its regenerative capabilities via pro-angiogenic and anti-inflammatory activities. Based on the previous studies, our lab wanted to understand how the different extracellular matrix composition affects iPSC vascular smooth muscle cell paracrine secretion. Specifically, we looked at the density and the addition of biofunctional molecules such as hyaluronic acid, laminin, and fibronectin. To assess for density, we used type 1 collagen-based scaffolds. We were able to manipulate the density of the scaffolds by changing the concentration of the collagen. So 1.25 mg per ml is the least dense, and 4 mg per ml is the most dense. The cells were embedded into those scaffolds and incubated for 72 hours. The supernatant were used for paracrine growth factor evaluation, and we also use LMR blue for cellular viability evaluations. To investigate for the biofunctionalities, we made the scaffold in the same way with the addition of biofunctional molecules at different scaffold densities. The cells were also embedded into those scaffolds, incubated for 72 hours, and the supernatant was evaluated for paracrine growth factors. And we also evaluated cellular viability in those biofunctional scaffolds. For our density experiment, we demonstrated that at higher densities, there is a both increase in cellular viability and pro-angiogenic growth factor secretions, specifically VEGF and BFGF. We looked at the biofunctional molecules effects on vascular smooth muscle cell survivability in those different collagen densities, and we saw an overall increase in viability with increasing in density, except in the medium density scaffolds. We also assessed for the VEGF secretion in the biofunctional scaffolds at different densities. While we do see an increase in VEGF in the lowest density, where there is no significant changes in the medium or high density. However, we do see that the VEGF secretion was higher in high density scaffolds, and that's irrespective of what the biofunctional molecule were added. So this confirmed that VEGF secretion was only dependent on the scaffold density and not by the biofunctional molecules. Furthermore, we screened for other growth factors in those biofunctional scaffolds and found that BFGF was significantly elevated in the scaffold containing fibronectins, and there was an increase. There's a dose increase in the BFGF secretion with increasing amount of fibronectins. Lastly, we added PEG to the scaffold containing fibronectin and saw the BFGF secretion reverted back to the basal level. So in conclusion, we found that high collagen density scaffolds, they promoted the smooth vascular cellular viability, and the VEGF secretion was dependent on the collagen density. The BFGF secretion from those cells was fibronectin dose dependent. So overall, we gained a better understanding of how the extracellular matrix composition affects the iPSC vascular smooth muscle cells. This hopefully will optimize those cells as a viable therapeutic agent for wound healing. And lastly, I would like to thank Dr. Henry Shaw of Yale School of Medicine for giving me the opportunity for the research and investigation. Thank you.
Abstract number 44 is dysregulation of hypoxia signaling limits skeletal muscle regeneration following injury and aging.
Hello, my name is Yuri Endo. Today I'm going to be presenting a study entitled Dysregulation of Hypoxia Signaling Limits Skeletal Muscle Regeneration Following Injury in Aging. So in our preliminary study, we have discovered that old muscle has impaired muscle regeneration following injury. So we have induced cryo-injury in young and old mice, and we evaluated the cross-sectional area of muscle fibers on both DPI 5 and 10, and discovered that old mice had significantly reduced cross-sectional area of muscle fibers, indicating that they have impaired muscle regeneration capacity. We isolated skeletal muscle precursor cells from both young and old mice, and we have discovered that while the number of SNPs were decreased in aged skeletal muscle, their ability to differentiate did not differ from that isolated from young mice. And we also found that aged skeletal muscle had significantly reduced levels of ANT and HIF1 alpha on uninjured muscle fibers. And this discovery has led us to a hypothesis that the loss of aged skeletal muscle's ability to regenerate was due to this loss of ANT and HIF1 levels in aged skeletal muscle. And in order to test our hypothesis, we have created transgenic mice with inducible skeletal muscle deletion of ANT. And we have discovered that on both DPI 5 and 10, the cross-sectional areas of injured skeletal muscles were significantly reduced in the transgenic mice with muscle-specific ANT knockout compared to the wild-type control. And this change was associated also with a significantly decline in the activation of notch signaling as indicated by reduced levels of NICDs in skeletal muscle. We then rescued the ANT activity using a pharmacological activator of hypoxia signaling, which acts by aiding the MO228 HIF1 translocation as ANT does. And we have found that the injection of MO228 into old mice has rescued its ability to regenerate on both DPI 5 and 10. And this was also associated with a significant increase in the levels of notch signaling pathway activation. We have further found that this effect of ANT is partially brought about through notch signaling. We have found this through an injection of DAPT, which is an inhibitor of notch signaling. And injection of DAPT has masked the ability of MO228 to rescue the ability of the aged muscle to regenerate. So in conclusion, aged skeletal muscle has a dysregulation in the hypoxia signaling pathway. There is a loss of ANT in aged muscle. Loss of ANT in myofibers results in diminished regenerative response in skeletal muscle, and ANT seems to mediate its effect on muscle regeneration partially through notch signaling. Thank you so much for this.
The final abstract is the effect of topical tacrolimus on pedicle flap vascularity, a histological analysis.
Thank you for allowing us to present our research today. Skin necrosis is a common problem, occurring in anywhere from 2.5% to 60% of mastectomy flaps. One institution cited the cost of treating mastectomy flap necrosis at anywhere from the hundreds to tens of thousands of dollars, depending on the severity. With over 100,000 breast reconstructions a year, the cost of treating skin necrosis can range into the hundreds of millions of dollars.
The pathophysiology of necrosis is primarily driven by a lack of arterial flow. The lymphatic congestion, followed by venous congestion, and ultimately arterial insufficiency plays a role as well. Tacrolimus is a macrolide calcineurin inhibitor. Topically, it's used to treat cutaneous inflammatory diseases, and systemically, it's used for the prevention of transplant rejection and autoimmune diseases. It acts in T cells by binding the FK506 protein, and the resulting product inhibits calcineurin. This in turn inhibits T lymphocyte signal transduction and IL-2 transcription. In doing so, it prevents T cell activation and differentiation of CD4 cells, and thus exerts its immunosuppressive effects. CD4 cells play a critical role in initiating and guiding inflammatory processes, as well as the development of fibrosis and lymphedema. A 2017 study showed that topical tacrolimus in a mouse tail lymphedema model had decreased levels of inflammatory markers, inflammatory cells, and fibrosis, while also improving lymphatic collateral growth and function. We previously hypothesized that topical tacrolimus may alleviate one factor of tissue necrosis in this way. In that study, we raised and reinset 22 dorsal skin flaps on rats and then treated them with daily tacrolimus or petroleum jelly as a control. The results demonstrated significantly decreased full-thickness necrosis in flaps treated with tacrolimus as compared to the control. The purpose of this study was to investigate the vascular and histological differences between these two groups in order to identify the etiology of our research findings. We used an established Sprague-Dawley rat model for skin necrosis. We first verified the model by raising and reinsetting a 3 by 10 centimeter cranially based dorsal skin flap on 10 rats. Each rat was anesthetized and provided analgesia. They were then shaved and marked, with landmarks being the midline and the base of the scapula. They were then prepped and the flaps were sharply raised and reinset. Once we verified that this type of flap exhibited consistent necrosis, we raised flaps in the same fashion for 22 study rats. Each rat was randomized to receive either tacrolimus or petroleum jelly with 0.2 grams of either ointment being spread over the flap and the shining area. They were then covered with an occlusive dressing. From there, the ointments and dressings were changed daily, and the rats were sacrificed post-op day 7 and the skin flaps removed. 2 blinded reviewers marked the total skin area, as well as the areas of viable tissue, reversible ischemia, and necrotic tissue. Full-thickness punch biopsies of each area were taken from 2 randomly chosen animals in each group. The paraffin-embedded tissue was sectioned to generate H&E stain slides. Representative images of each area of the flap were taken under magnification using light microscopy. Arteries, veins, and lymphatics in the dermal layer were quantified under blinded conditions by trained pathologists and calculated per cross-sectional area using Fiji software. For viable tissue, the control group had an average of 12.5 vessels per sectioned area, while the tacrolimus group had 20. For the areas of reversible ischemia, the control group had an average of 6 vessels, while the tacrolimus group had 11.5. And for the areas of necrosis, controls had an average of 0 vessels, and the treat group had an average of 5.4. In our study, we found that there was a trend toward more vasculature in the tacrolimus treat groups, which may provide some insight into our previous study findings, and why tacrolimus was associated with significantly decreased skin necrosis. In conclusion, our rat model demonstrated that topical tacrolimus was associated with significantly less skin necrosis, as well as increased vasculature in all areas of the pedicle flaps. It is a readily available medication and may improve flap survival in high-risk patients. Thank you.
So we'll now open up for questions and answers. Dr. Marara?
Yeah, I was just typing, sorry. You know, a whole bunch of very good studies. Dr. Wang, can the vibration technology be used for patients post-op with post-operative pain? You know, we're concerned about propofol, of course, but we're more concerned about post-op pain for our patients.
I think that's a very interesting question that you bring up. Of course, our study did not actually focus on that, but I think that's a very valid point. That's something that we've been discussing as a future direction, is how we can improve the entire operative experience for our patients. I do think it is based on the literature and based on our own findings, I do think it is feasible to think that we can transition this into the post-operative phase, and that is something that we are interested in doing. But it was a very good clearly a very positive result that we found that this could be an effective
modality for us to use just prior to the operation, that our patients weren't in such significant discomfort. But I think that is a very valid point, and that's something that we're going to try to hopefully investigate as well.
How well do you think patients can remember?
Yeah,
propofol does have amnestic qualities.
Right, and that was brought up we had a very extensive IRB review for this project for that exact reason, and there were some anesthesiologists on that review board. The interesting thing is, yes, it does. Obviously, some patients won't remember it, but it's actually quite interesting because a lot of the patients do, and some of our own personal experiences where a lot of our patients said the most uncomfortable thing that they remember from the procedure was the propofol injection just before they went under. So that was kind of the reason why we even thought of this as an experiment to begin with. But you do bring up a very valid point, and that was discussed pretty extensively. So it is a limited study in that regard, absolutely.
Thank you.
Thank you.
Jess, you have questions? Or, I mean, I have more I can ask.
Yeah, I do have a question actually. So do you have a sense of the physiology that's underlying this phenomenon? Do you think it's the gatekeeper effect or some other neural pathway?
Yeah, so through the literature review, yes, there was the gatekeeper effect that was definitely mentioned. I think also another theory was I don't know if distraction is the correct word technically, but in a layman's terms, with the delta fibers and this in the pain receptors, one of the more cited research was that it is more of a desensitization effect that is contributing to this on a more physiologic level.
Thank you.
Thank you.
Ishani, adenoviruses cause a lot of inflammation. How do you know it's really angiogenesis rather than inflammation that's causing the fat grafts to stay? And then number two, these adenoviruses can be fairly toxic and have off-target problems. Do you think it's clinically viable to justify using gene therapy for improved fat graft take?
Thanks so much for the question. I think first, as far as whether it's inflammation versus something else, we did not stain in these particular mice, but we would in future studies to make sure to see that it is in fact angiogenesis. And then as far as whether we could use gene therapy, I think it's a viable point. We've seen this used in other studies that have shown that it's viable in a human model, but the reality is fat grafting is still extremely unpredictable, and if we could achieve significantly improved rates, I think you would consider it, but further studies are needed. Our sample size was still quite small, but all good points.
Hi, yeah, my question was also for Ishani. How likely was or could you conceive of this being shelf stable for human use in the future?
That's a good question. The company that has provided the adenovirus believes that it is shelf stable. We keep them, when we receive the adenovirus, we are able to use it over the long term, but again, we are only using them in a mouse model, and it's a highly controlled environment in a very small amount of fat. So all of those things would have to be taken into consideration, but the company is actively working on that.
Perfect, thank you.
Kalti, did you, Kalti Dwan, this is a question for Kalti Dwan. Did you look at the differentiation potential of the stem cells that were cultured in the different scaffolds? I think it's interesting to see if the cells grow, but I think it's more interesting to see if they either retain or improve their differentiation potential.
Yeah, hi, thanks for the question. We did a couple of stainings, but what we found is that the iPSC vascular smooth muscle cells, they're very pure in terms of what they are. The things that we had the iPSC, and then we differentiate it into the vascular smooth muscle cells, and then those cells retain their morphology and then their phenotypes and stuff. So we didn't look at its other differentiation potentials.
And Kai, how would you translate this into the clinic? You mentioned wounds, but specifically based on your findings?
Yeah, so what we found is that we saw an increase in pro-angiogenic growth factors, and this is in vitro. And the next step, what we want to do is to do in vivo, and we have set up a couple of experiments before the COVID. And what we wanted to do is to look at the mice studies by inducing a wound in both normal mice and diabetic mice. And then we're gonna put our scaffold into the wounds for 14 days and then take it out and then stain it and then look for cellular migration, any sort of angiogenic factors, and then look for a new vessel formation and see how that can translate into, say, mice. And then the next step is probably see if we could do anything like clinical.
Awesome, thank you.
Yori, what do you think of the mechanisms that regulate ARNT expression in muscle cells? I think it's interesting that it's decreased, but do you know how this expression is decreased in the stem cells?
In stem cells, or so we didn't really specifically look at stem cell ARNT expression in our experiments. We actually looked at the whole muscle ARNT expression, and that was decreased. And that was one of the questions why we are interested to look at the stem cell differentiation ability, and we found that their ability to differentiate actually wasn't affected with aging. So it's really interesting to answer your question. We didn't really look at the ARNT expression within the stem cells, so I can't really tell you if they are different or not, but in the whole skeletal muscle, it seems to be decreased with aging. And I also don't know the mechanism that determines the level of expression that changes with aging as well.
Yeah, I'm really interested because I want to know why my muscles are not working anymore. So
oh, really?
Please figure this out.
Yeah, there's a global downregulation, it seems, in hypoxia pathway, including ARNT, but we haven't discovered what causes that, and we are kind of going upstream in our future study to figure out, and we think it might be the PHD enzyme that degrades the HIF enzymes, and HIFs are obviously the transcription factor that globally regulates the hypoxia pathway. So we are thinking maybe that the increase in the level of PHD enzymes might be responsible. So we'll see.
Good. Yeah, no, it's interesting because, you know, aging has so many different effects, and we can see a lot of downstream changes, but we don't know what the sort of the instigating issue is. So I think that's the problem.
Yes, we will try to go upstream as well in our future study.
Good, good.
Thank
you.
Yori, did you do any, for the ARNT knockout mice, did you do any whole mouse tests of strength or speed or anything like that?
So we are currently doing that in our studies, and we do find that there was a significant decrease in their ability to sort of adapt to the resistant exercise training. So their maximum distance of running, max speed of running, and we just tested the muscle strength as well. So the force per cross-sectional area was significantly reduced as well. And so I think, there was a physiological effect that was obviously observed. And that was very similar to what we observed in aged mice as well. It kind of mirrors.
Cool. Okay, thank you. So the last question, Dr. Vaughn, you showed that tacrolimus improves the flap vascularity. Why do you think that is? I mean, I know that it's inflammation and lymphatic staining, but it doesn't really make a lot of sense to me that tacrolimus would increase the number of cells. Do you think the number of vessels are actually decreased in the non-viable tissues rather than the other way around?
I mean, that's absolutely a good question. So I don't have, a straightforward answer for you as to why we would think that the vascularity is increased with the tacrolimus study. We certainly expected to have more lymphatic vessels there based on, your previous studies, which is one of the things that we, wanted to at least confirm. As far as why there's increased vessels, both venous and arterial, I can't really quantify or give you a good answer for that. That is certainly something that we are looking into, though, and we'll be studying in the future.
Let me ask you this. Was the number of vessels increased as compared to normal tissues?
So it was increased in all things. So on the flap, it was a pedicled flap based superiorly. We took samples from pretty much 3 different areas. One would be close to the base, which would be usually the viable tissue. One about in the medial area, which is the area that we deemed a reversible ischemia, like skin that could potentially still heal. And then also skin distally, which was grossly necrotic. So we took the biopsies from those 3 areas, from both the rats treated with the tacrolimus, as well as the rats treated with just the control petroleum jelly. And when comparing viable tissue to viable tissue, ischemia to ischemia, and reversible to reversible, there was increased vascularity in all of them in the tacrolimus treated group.
That's interesting. Yeah, I think, you know, lymphatic flow is probably important in regulating venous stasis. One can imagine that if you have increased lymphatic fluid stasis, you can worsen your venous stasis. And I think a lot of these flaps die because of venous congestion rather than arterial insufficiency. But it'll be interesting to see, you know, what you guys can figure out, you know, further.
For the sake of time, we'll cut the discussion off there, but thank you all and congratulations on excellent abstracts.
Great, thank you guys.
Thank you for a wonderful research session that was incredibly clinically relevant. And now for the last session of this meeting is the practice session to be moderated by Paris Butler and Jeffrey Guzinoff.
Good morning. Our first abstract is going to be our U.S. plastic surgery residency programs equipping trainees to take on the opioid epidemic, a national survey.
Thank you for the opportunity to present. I'll be discussing whether U.S. plastic surgery residency programs are equipping trainees to take on the opioid epidemic, results from our national survey. The United States opioid epidemic represents one of the most profound threats to public health and has required every physician to consider their role in reversing its trajectory. It's well known that plastic surgeons overprescribe narcotics, and recent survey-based literature has suggested that U.S. plastic surgery trainees prescribe significantly more post-operative opioids than their Canadian counterparts, and thus lack critical opioid stewardship behaviors. However, it's unclear why this practice gap exists. Thus, there's a critical need to understand how plastic surgery programs can prepare trainees to be accountable and conscientious surgeons. Our objectives were to determine the availability and efficacy of opioid-related education and to identify where knowledge and practice gaps exist in order to lay the foundation for future educational efforts. We designed an anonymous web-based survey that, through program coordinators and program directors of all 97 programs, was distributed to U.S. plastic surgery trainees. Opioid-related education was categorized into formal training or purposeful teaching or planned curriculum and informal training, which included a learn-as-you-go method or the experience from seeing the practice of others. Our results, 91 respondents were included. The majority came from integrated residency programs. There was relatively even distribution across all postgraduate years. Most survey respondents attended programs in the Northeast and practiced in an urban setting. With regards to safe opioid prescribing knowledge, 60% of residents reported not knowing how patients can safely dispose of unused opioids. 70% of residents do not know any preoperative screening tools, and nearly half do not know how to query drug monitoring databases. There was no significant difference in knowledge of these specific safe opioid prescribing practices between junior and senior residents. When discussing opioid prescribing rationale, 8% of junior residents reported always asking for rationale, and only 4.1% of senior residents reported always providing rationale. 59% of respondents received formal training, with the most common setting being didactics or departmental conference, followed by online training. The most common topic covered by formal training was reversal of opioid overdose, followed by use of adjuncts and patient counseling. Conversely, nearly 91% of respondents had received informal training, with the most common forms being instruction from a senior resident or attending, both with further explanation and clarification and also without. Only 59% of participants who had formal training found it to be valuable, whereas the vast majority, 95% of respondents who had informal training found it to be valuable. Among respondents who had both forms of training, the vast majority found informal training to be more valuable. So what does this tell us? Plastic surgery residents lack knowledge related to essential safe opioid prescribing practices. Previously, it was unclear why trainees did not act as opioid stewards. It appears that it's not because of a lack of time or interest, but more so because trainees are not receiving the necessary education to be conscientious opioid stewards. The fact that knowledge was equivalent among junior and senior residents was especially concerning given the prevalence of informal training, which really relies on senior to junior teaching. And while it's possible that junior residents received earlier opioid education in medical school, it's clear that plastic surgery programs have not changed their curriculum in step with this. Informal training was found to be significantly more valuable and common than formal training. We explored these with free text answers and then categorized these free text answers to better understand why respondents found this to be true. So the value of formal training came from removing personal and attending bias and helping to manage expectations. Values that were similar in both formal and informal training had to do with guidelines on specific and safe dosing and regimens. And with regards to informal training, respondents appreciated the real-world applicability and instruction from experienced mentors. The next natural question is, how can we draw on the relative strengths of each of these training types? In other words, how can we formalize informal training? This is based on the notion that both formal and informal training have relative strength and play a role in preparing young surgeons to be opioid stewards for the next generation. Thank you, and I'm happy to take any questions.
Thank you. Our next lecture will be Decreasing Recurrence After Keloid Excision with Sequential Triamcinolone Injections.
Good morning. My name is Nick Kunda. I'm a second-year independent plastic surgery resident at the Nassau University Medical Center, Stony Brook University program, affiliated with Long Island Plastic Surgical Group. Thank you for the opportunity to present my research this morning. The title of my presentation is Decreasing Recurrence After Keloid Excision with Sequential Triamcinolone Injections. We have no disclosures. Many different techniques have been described in the literature to try to minimize keloid recurrence after excision. In this presentation, I'll describe an easily reproducible technique using surgical excision, sequential triamcinolone injections, and close clinical follow-up. This technique is safe and effective and can easily be incorporated into one's surgical armamentarium. Our patients were brought to the outpatient ambulatory surgical center or to the office setting and underwent general and/or local anesthetic. An elliptical incision was made around the base of the keloid, and circumferential dissection was performed until normal tissue was encountered. The keloid was then excised in its entirety. The edges were undermined as needed for tension-free closure, and the wound was then irrigated and hemostasis was achieved. The wound was closed meticulously with sutures. Either 10 milligrams or 40 milligrams of triamcinolone was injected intraoperatively, depending on the size and location of the keloid, followed by a bacitracin dressing. Patients were seen 7 to 14 days post-operatively and were instructed to begin scar massage and biocorneum applications once the sutures had either dissolved or were removed. The patients were then reevaluated every 6 to 8 weeks, as indicated by their clinical course. In the first part of our results section, some of the patient demographics are seen. Approximately 56% of the patients examined were African American, 26% were Hispanic, and 16% were Caucasian. The average age of patients in our study was 18 years old. 80% of the patients were female and 20% were male. The location of the keloids varied between the ears which were 80% of our patient, the facial or submandibular region, which was about 13% of our patients, and the chest or trunk region, which was 6.6% of the patients. The average size of keloids excised was between 1.1 to 2 centimeters. The most common injury causing the keloid was a piercing in 73% of patients, surgery in 10%, and burns in 3.3% of patients. The average age of injury was 13 years old, and the average age of onset of the keloid was 15.6 years. Symptoms reported by the patients were discomfort in 40%, self-consciousness in 23%, and itching in 16%. 60% of patients that we saw had no previous treatment, 20% had a previous injection, and 6.6% had excision only. The type of anesthesia used in our study was local, which was seen in 73%, or general and local, which was seen in 26%. We used 40 milligrams of Kenalog in 60% of our patients and 10 milligrams of Kenalog in 40% of our patients. Again, this was based on size and location of the keloid. We also used various sutures, including fast-absorbing chromic, monochrome, and Vicryl. We had 0 post-operative infections and 0 wound dehiscence. Some side effects we did see were hypopigmentation in 13% of patients, skin thinning in 10%, and telangiectasias in 3.3%. The total number of patients that received follow-up triamcinolone injections was 73.3%. The average number of follow-up injections per patient was 1.84, and the average number of appointments that patients followed up was 3.0. Patients, as well as their parents, are extremely averse to chemotherapeutic agents or radiation therapy as part of their treatment regimen. Furthermore, chemotherapeutic agents may be difficult to obtain in the outpatient or ambulatory surgical setting. Triamcinolone is both easily available and it has a low side effect profile. In conclusion, this study illustrates a technique that is safe, effective, and easily reproducible. We found an overall recurrence rate of 23%, which is superior to many of the current techniques described in the literature. This technique can be used by a wide range of surgical subspecialties across various office-based and hospital settings. Thank you for the opportunity to present my research, and I welcome any questions.
Thank you. Our next abstract is Gender Disparities in Job Satisfaction in Academic Plastic Surgery.
Good morning. My name is Brandon Smith, and I'm proud to present Gender Disparities in Job Satisfaction in Academic Plastic Surgery. Women in the field of plastic surgery face significant barriers to entry and advancement that have been well documented. This has created an environment where women remain grossly underrepresented in the field, despite the known benefits their diversity brings to the practice of plastic surgery. In academia, which holds many important roles towards leadership and mentorship, women face disproportionate attrition in the field. Knowing that job dissatisfaction is an important aspect of field attrition, we wanted to better understand if women in the field of academic plastic surgery face increased job dissatisfaction compared to men. Therefore, the goal of this study was to evaluate gender disparities in job satisfaction in academic plastic surgery. To do this, we first started by creating a list of all of the academic plastic surgery programs in the U.S. We then emailed the directors of those programs a 15-question survey to be redistributed to faculty and residents for completion. We received 380 unique responses from this survey. The survey itself was designed based on the Andrews and Withy questionnaire, a validated survey designed to measure job satisfaction. Using 5 different questions about one's job, it measured 5 unique aspects of satisfaction, including one's overall satisfaction with the job, coworkers, work tasks, work environment, and work resources. Respondents were able to rate their satisfaction with each of these aspects of the workplace on a Likert scale, with 1 indicating they were delighted and 7 indicating they were terribly dissatisfied. We compared these scores by t-test, with results considered significant if the p-value was less than 0.05. Moving on to the results. Looking first at the demographics of the respondents, we saw that overall, approximately 1/3 of total respondents identified as women. Female respondents were, on average, younger than their male colleagues, more likely to be residents or fellows, more likely to have had integrated residency training, less likely to be in senior academic positions, and less likely to report being in leadership positions. Next, we'll look at the results of the survey itself, and for ease of interpretation, we'll have the 5 satisfaction measures on top, and the group or subgroup of individuals being compared for each satisfaction measure here on the left. For each group of individuals, we use happy faces to indicate aspects of the job where there were no significant differences in male and female satisfaction. We use sad faces to indicate areas of the job where women reported significantly more dissatisfaction than their male peers. So when we looked at comparisons of job satisfaction for all of the women in the survey versus all of the men in the survey, we saw that overall, women were significantly more dissatisfied with their work environment, which again included physical surroundings, hours, and the amount of work, as well as their work resources, which included work equipment, information, and supervision, than their male colleagues. Next, we wanted to explore the job satisfaction held by different subgroups of respondents to see if there were any disproportionately affected by workplace dissatisfaction. We saw that in regards to self-reported race, Caucasian women were significantly more dissatisfied with their work resources than Caucasian men. Interestingly, in regards to self-reported relationship status, single women were less satisfied with available work resources than single men. Additionally, women in a long-term relationship, including marriage, reported decreased satisfaction with their overall job, work environment, and work resources compared to men in a long-term relationship. Women at the attending level, when compared to male attendings, were less satisfied with the work environment and work resources. In regards to residency training, women who had completed integrated residency were significantly more dissatisfied with their overall job and work resources than men who had completed integrated residency training. When delineated by academic position, women in the assistant professor and associate professor positions were more dissatisfied with their work resources and work environment, respectively, than men in similar academic positions. Women in leadership positions, including residency director, fellowship director, and chair, reported greater dissatisfaction with work resources than male leaders. Regionally, women who reported working in the Southern Census region reported greater dissatisfaction with work environment than their male peers, while those in the Western Census region reported greater dissatisfaction with both their overall job and work environment. Finally, we wanted to understand if there was a temporal component to these findings. What you see in each of these boxes is the Pearson correlation coefficient measuring the strength of the relationship between age and reported Likert score for workplace satisfaction. We found that for women, there was a significant relationship between increasing age and greater dissatisfaction with work environment and work resources. So, to conclude, this study demonstrates significant differences in job satisfaction between male and female academic plastic surgeons. These differences extended to specific aspects of the workplace and affected certain groups disproportionately. Understanding who these job disparities affect and why they occur is an important first step towards improving representation in the field, as well as student mentorship. Thank you.
Our next abstract is A New Decade for Diversity, Trends in Female Representation at NESPS.
Hi everyone, my name is Helen, and it is a privilege to present on behalf of my team today at NESPS our project titled A New Decade for Diversity, Trends in Female Representation at the Northeastern Society of Plastic Surgeons. For disclosures, Dr. Broderick is a consultant for Margin Probe. So the mission of the Northeastern Society of Plastic Surgeons is to be a collegial forum for plastic surgery education and professional growth, and is founded upon the values of education, integrity, camaraderie, and inclusivity. In recent years, there's been a lot of interest in the representation and visibility of women in conferences, such as recent studies of women in general surgery or craniofacial conferences. This is important to examine, especially in the Northeast, because a lot of the good research and leading research begins and is shared within this region. So why is gender diversity so important in surgery? There's a lot of really good answers, but one of the most important is that the provider teams should reflect the population they provide for, leading to improved communication. The inherent value of diversity is often studied, including a JAMA Surgery article that also found that conference representations with mixed gender authorship were more likely to publish in peer-reviewed journals. Unfortunately, though, females remain underrepresented in plastic surgery. So this figure is called the leaky pipeline, is often referenced by Dr. Susan McKinnon in her gender diversity talks. It depicts how despite the entering medical school class being majority female, as you progress up the academic ladder in plastic and reconstructive surgery, the representation decreases, resulting into 17% of female active memberships in ASPS. So the issue here is both recruitment as well as retention. So the purpose is to characterize trends in female representation at NESPS within these categories. In order to accomplish this, we reviewed programs from between the years of 2013 to 2019 within the categories. Within poster presentations and podium presentations, we recorded the first and senior author participants, which were then further organized by topic. The genders were then identified through web searches. So with our preliminary results, in 2013, only 1 in 4 registrants were women. By the year 2019, 42% of registrants were women, and a lot of this increase happened between 2017 and 2019. Of note, last year was the first year that the percent registration of women was not statistically different from that of men. Speakers, panelists, and moderators are an especially important category due to the large amount of literature that talks about how the increased visibility of these positions is very special for as role models for recruitment and retention of women in surgery. So in 2014, to give you an idea of what this looked like, of the 13 speakers, 0 were women. Of the 23 moderators, only 4 were women. And of the 19 panelists, only 3 were women, and all 3 of them spoke in Goldilocks and the 3 breasts, thin, obese, and just right. Following was a spike in 2017. Last year, there was only 1 female speaker, and that was Dr. Andrea Pusick in the Women in NESPS luncheon. For poster presentations, it's interesting to note that trends in first authors seem to tail behind the trends in the senior authors. For podium presentations, similarly, first authors seem to mimic the trends of the senior authors, but what's very important to note here is that, like the leaky pipeline, first authors have more female representation than senior authors, and this is congruent because first authors are often residents, medical students, or undergraduate students who are further up the pipeline, whereas senior authors are often attendings who are further down the pipeline. Within the podium presentations by topic, there are also a lot of interesting trends. For both breast and research, there is an optimistic increased representation of females. However, for CMF Pediatrics, there is actually a decrease in the first author representation between the years of 2016 to 2019. So in summary, while women remain underrepresented in NESPS, it's important to note that there is a promising upward trajectory. This is especially visible through the registration trends. We also want to note that perhaps this is actually the senior authors and the speakers, panelists, and moderators that are helping drive the first author in the registration uptick. So limitations of the study is that gender is not binary and that results are only correlatory and there's no causation drawn. For future work, it'd be very interesting to investigate the impact of COVID-19 on female representation and the impact of the Women in NESPS program. Interventions to investigate include implicit bias workshops, mentorship, networking, and social media. Thank you so much for the time, and I would like to acknowledge our investigators.
And our final abstract is evaluation of a simulation-based mini elective on medical student interest in plastic surgery.
Hello, my name is Eva Roy, and I'm a medical student at Pitt Med. Today I'll be presenting an evaluation of a simulation-based mini elective on medical student interest in plastic surgery. Currently, exposure to plastic surgery in preclinical years of medical school is very limited. As someone who has just finished her first 2 years of medical school, I can say that there are very few opportunities to get exposed to plastic surgery in a structured way. In addition, the integrated plastic surgery programs are becoming increasingly popular and competitive, so it's vital for students to get involved and exposed early. However, many medical students are unaware of the diversity of the field, research opportunities available, and the different paths to residency. Ultimately, this has led for a need for a way to provide preclinical medical students a way to learn about plastic surgery in a structured setting. So our goal was to create an opportunity for medical students to learn about the diverse field of plastic surgery through a variety of lectures, engage through hands-on simulation experiences, discover clinical and basic science research opportunities, connect with resident and faculty mentors, and prepare applicants for the match process and possibly a career in plastic surgery. So a plastic surgery mini-elective curriculum was developed for preclinical medical students. Mini-electives are courses that are offered to preclinical medical students to learn about unique topics in a stress-free environment, as they are purely voluntary and not graded. The plastic surgery mini-elective consisted of 5 3-hour sessions from January to February of this year, with each session consisting of a didactic lecture followed by a simulation-based component. A pre-course and post-course survey was administered to identify interest in, awareness of, and barriers to the field of plastic surgery. Each week there was a different focus. The first week consisted of an introduction to plastic surgery followed by a basic suturing session. The next week focused on craniofacial surgery followed by learning how to do palatoplasty markings and looking at different 3D craniosynostosis models. The following week focused on breast, microsurgery, and aesthetic plastic surgery followed by a facial analysis and drawing session. There also was a week on hand surgery and learning how to do a hand exam, and the final week consisted of learning about research opportunities available in an interactive resident panel. We had 25 students complete the pre-course survey and 22 complete the post-course survey. Majority of students were female and first-year medical students. Looking at the overall experience, 100% of students strongly agreed that the mini-elective increased their knowledge of plastic surgery. In addition, 100% of students strongly agreed that residents and attendings engaging with students improved their experience, and 95% of students strongly agreed that the mini-elective promoted interactions between students and attendings. Looking at the pre versus post survey, there was a 34% increase in plastic surgery as the top residency to which students would most likely apply. 77% strongly agreed they felt more comfortable in seeking out a plastic surgery mentor, and 86% planned to get involved with research. In addition, there was a 100% awareness of the independent and integrated path on the post survey. Looking at the simulation component, students' self-rated ability to perform a laceration repair, knot tying, craniofacial exam, evaluating a hand x-ray, assessing wound recon, identifying breast recon options, and initiating and completing a hypothesis-driven research project also improved. Overall, this is a simple curriculum that can be adapted by other institutions, and it's a concept that can be applied to other specialties that might not have access to preclinical medical students, and it can provide numerous benefits to both medical students and programs. For example, for the student, they can gain knowledge of the field, have access to residents and mentors, and the potential to develop longitudinal relationships, and most importantly, allow further exploration of the field through shadowing, research, and rotations for the next 3+ years. For the institution, it allows early exposure of the field that many medical students might not get until their 3rd or 4th year. They can provide mentorship, help prepare applicants, and increase awareness of the different paths to residency. In conclusion, this is a positive way to increase interest and awareness in the field. It can provide access to residents and faculty for mentorship and research, and the mini-elective can help prepare medical students for the match and a career in plastic surgery. Thank you to all the faculty and residents for making this mini-elective possible, and we hope that this mini-elective can help engage medical students and help shape the future of plastic surgery. Thank you.
All right, we're going to start our question and answer session. Paris, you want to lead us off with number 46?
Yes, with number 46. So good morning. All were well presented. Congratulations to all of the presenters and authors. So I'll start with number 46. So Dr. Sharif Asghari, in your conclusion, you state that the trainees prefer informal training over formal training, and that this paper lays the framework for, quote, formalization of informal training. So my question to you is, how do you and your authors suggest we operationalize this formalization of informal training?
So when we gathered our free text responses, one kind of concept that came up over and over again that respondents seemed to really appreciate and seemed to kind of glean the most information from were ERAS protocols. And they kind of cited the idea that they're formal and that they're evidence-based and they're multidisciplinary, but informal in the sense that they are applied to very specific plastic surgery cases, and they kind of contextualize practice. So the development of more kind of ERAS protocols would be one route to take. Another kind of idea would be just to dedicate more kind of educational funding towards this. As of 2020, I think PSF has only attributed funding to about 3 projects related to opioid education. So I think we need more kind of longitudinal studies to look at how that might occur.
Okay. An additional question is, did you see any regional or demographic, say rural versus urban trends in your responses? I know that you had a preponderance of regional responses, but did you see differences in those responses according to the region in which they resided?
We initially did expect to see that, but unfortunately, I believe we were underpowered and we didn't see any differences when we compared across regions.
Dr. Gusnop, did you have any additional questions?
No, I think one of the big issues though is like residents are really operating in a vacuum after cases are complete. So, you know, they get calls in the middle of the night for pain. They have no idea what kind of wounds these patients are dealing with. And, you know, are we swinging the pendulum too far in terms of opioid control and forcing our patients to almost appear as if they're drug seeking when they really have problems that need to be treated?
Yeah, I think that that's certainly kind of a concern. Post-operative pain is very real, and as physicians, we need to be cognizant of that. We don't want our patients to be miserable. Some advice that was always given to me was you can always prescribe more opioids, so it's okay to kind of start at lower doses, at lower amounts, and then kind of reassess. I think what's most important is that when a patient does call in the middle of the night, that you actually go kind of either see them or you get the appropriate information regarding their surgery, what medications they were given, did they fill it? Are residents aware of how to kind of check with pharmacies to determine whether the prescription was filled? Do they know about prescription drug monitoring databases? I think all of those kind of things give us clues as to how to best approach patients when they need or are asking for more pain medication.
Great, thank you.
So I'm going to move on to number 47. Dr. Kunda, once again, very well presented. Those of us that treat a lot of keloids recognize that the devil's in the details. So I'm going to actually ask you to be a bit more granular with some of the specifics of your study. So as an example, and this was actually brought up with some of the viewers in our chat box, what was the final suture layer that was most frequently used? So was it a permanent material? Was it an absorbable? And then I know that there was a combination of them used, but did you assess the differences between the two? Also, you know, I guess the fashion in which the final layer was closed. So was it an interrupted fashion? Was it done in a running, say, you know, over and over, or was it done in a subcuticular fashion? So I'll start with that one.
Sure, thank you for the question. So most of the final layer was a resorbable suture type. That was about 83% of our patients. And that was in a running type. And what was the first part of that? I'm sorry.
So it was the technique. So you just described that. So it was a running suture, and then you said you used absorbable or dissolvable suture. You did not use permanent suture. Did you see a difference in the two?
Oh, that's right. No, we haven't actually broken it up to look at the different types of sutures. The big thing we didn't want to do is use any sort of vicryl or anything deep. That was the big thing we tried to avoid when we were doing it, if we used a layer closure. But otherwise, looking at the different types for the actual skin, we didn't kind of do any subset analysis of those groups.
Okay. And then I guess kind of in that same vein, pertaining to your triamcinolone, your group used 40 milligrams, you used 10 milligrams, and in my practice I used 40 milligrams. Did you all find a difference between those two? And how did you decide which wounds received the 40 versus the 10?
So it was really patient and location specific. In general, for overall, in 60% of our patients, we used 40 milligrams of Kenalog, just 1 cc total. We didn't do we didn't do a subset analysis. This is going to be more so for our paper to kind of look at all these subgroups and everything once we start getting ready to publish this. But most of the time it was just the 40 milligrams and 60% and, you know, just the 1 cc.
And
do you have a rule of thumb? Do you have a rule of thumb as to how much, you say 1 cc, but that may be a lot for a small keloid.
Exactly.
How do you know?
And it was difficult for us to actually inject the full cc, especially in babies in a small location with a small keloid. But we inject as much as we could. We don't have an exact amount of how much was actually injected, but we tried for 1 cc.
And then pertaining to follow-up, so I know, I kind of pat myself on my back and get excited when there's no recurrence at 6 months, but truth of the matter, it's about a year before we should really get excited. I know your follow-up was about 9 months, so I'm assuming you all are going to continue to follow these patients out.
Exactly. And one of the problems with this study is patients that don't follow up. I mean, we included them in no recurrence, but in actuality, did they have no recurrence? It's hard to say if they followed up somewhere else. But yes, we're going to keep continuing to follow these patients, and part of the next step is going to be kind of calling all these patients that were in the study to see if there's any issues with any recurrences or anything like that. But we assume patients that were lost to follow up had no recurrence.
One more quick one, Dr. Gustinov, if you don't mind. So I know that you all use biocorneum pertaining to your scar massage. Mederma is another silicone gel product. Did you happen to compare the two or any of the others that are out on the market?
No, we just, this was what was used in the practice and what was easily available out here. And so that's just the only thing we used was the biocorneum to try to keep that no different and keep that variable the same for every patient.
Do you have any additional, Dr. Gustinov?
Nope, go ahead.
All right. I'm going to move on to number 48. This would be for Mr. Smith. So in your study, it was also well presented. Do you know if this disparity in lack of job satisfaction amongst our female contemporaries exists in the private sector in addition to the academic sector?
So we distributed in our study to primarily academic centers. I think that the prevailing literature, is primarily academic. I think you could make assumptions, about the private sector based on that, but I would hesitate to make any definitive statements, based on the research that we've done.
So what would your assumption be, just because you brought it up? Do you think that women in private
my
practice
assumption
are
would be
as
that,
dissatisfied? Go ahead.
No, sorry. My assumption would be that a lot of the same issues that we saw in terms of work environment primarily would translate to the private sector. And for us, it was very broad, but tried to cover a lot of the research that we've seen in terms of how does your fellow staff treat you as a female physician. We've seen research where women, either do not have their requests or orders followed as diligently as their male colleagues. We have studies where they are treated with greater perceived disrespect in the OR by, either their colleagues or other OR staff. And that's not something I see as limited to the academic center or the academic environment because it appears to be more of a societal issue.
There. Do you think, or do you know, if these findings are consistent across academic disciplines, or is it something that's just unique to plastic surgery?
The research that we've done previously would indicate that it's probably worst in the surgical subspecialties, but is by no means limited to surgical subspecialties. This is an issue that's been prevailing throughout medicine and is one of the reasons why, it's important that they've started and continue to invest in initiatives throughout the whole field of medicine. But I think that here, in plastic surgery, we face the biggest disparities and kind of require the most help towards getting to a place where things are more equal and more equitable.
Someone in the chat had inquired if parenthood was assessed as a subgroup within your analysis. Was that the case? Did you look at that?
For parenthood, we used broader categories to try to focus on what may have played a part. Within those, it may have fell under work resources. In our write-up, we hypothesized that, if you're not provided the right resources for pregnancy, which has been shown in greater, more granular detail in other studies, it does negatively affect your perception of the field. We felt that this also possibly could have been covered when we looked at individuals in long-term relationships, those who are married, or those who are in long-term relationships, considering the future with children, they perceived greater dissatisfaction in those areas, which would have also covered individuals, who are thinking about a child, and are also in plastic surgery. And so we would say that, yes, it would have been covered in broader terms. And if you look more specifically, there are great authors who have looked at how women in the field are treated, when they are pregnant, and are expecting children.
You have any additional?
Brandon, can you just define what you mean by resources again? Is it like mentorship or grants or clinical resources or salary gaps?
So we listed a few examples, but there was no specification within the study, and that's definitely a limitation, but this was intended as a first step of where are people most dissatisfied and how can we follow up to get in more granular detail ideas of how to meet some of the limitations that we currently have in the field.
Okay, I'm going to move on to Ms. June, number 49. So also very well presented. In your study, you stated that you looked at the number of poster and podium presentations with female representation. Out of curiosity, did you look at the number of abstracts that were submitted? The reason I ask is there a way that we could potentially pick up on selection bias pertaining to who actually is fortunate to present at the NESP?
Yeah, actually, that's a fantastic question. Prior literature have also indicated that when names are associated with abstract titles or manuscript titles, if there's a female first or senior author, they're oftentimes not accepted at the same rate as their counterparts. That's a great point that I think we should take as our next step to see if there's a selection bias. Thank you.
And I guess along that same vein, how about panel selection?
Yeah.
Did you all inquire about that as well, looking at our processes? How can we potentially rectify that?
Yes, so of course, I'm not part of the selection process, so please, anyone on the line, please correct me if I have this incorrect. But I believe that most of those speakers are from the program committee and program chair and president. And there has been a lot of efforts that I have heard of recent years to increase diversity in selection, not just in gender diversity, but representation across all spectrums of diversity.
I think one of the...
Yeah, go ahead. Sorry, Jeff.
One of the things that I think may be helpful, and I've had problems on the national level trying to get some women on body contouring panels and finding people willing to speak on certain topics. Do you think there'd be value in having a sort of a go-to site for starting out with the NSPS of who'd be willing to speak on what certain topics, so that we have easier access of getting some, equality on our panels?
Yeah, absolutely. That's actually the first time I've heard of an initiative like that. And so I think that's a very creative way to address the fact that visibility for female surgeons is one of the big challenges. And so I think a website like that is exactly hitting the nail on the head and addressing the issue of visibility.
And I have one more question. So when you did this assessment of papers and podium presentations and even panelists, did you happen to find any outlying institutions that were doing it really well? They had a preponderance of excellent gender representation, just as kind of, best practices. We are getting good at describing many of these disparities, but we are short on rectifying them. So if we could find institutions that are doing it well, we should mimic it. Did you find any?
So we actually didn't stratify based on the institution itself, but it is important to value institutions that do promote gender equality. Our goal with this paper was to look at the society as a whole, so in the future we can break it down based on institution.
Paris,
You asked about the,
sorry, I wanted to just interject one thing about our process for selecting papers for this meeting was essentially entirely blinded. And so what's interesting is I think if you look back at this meeting, you've seen an incredible diversity, particularly gender diversity in both first authors and certainly presenters. And that was largely done just by the nature of who is submitting abstracts and the quality of their abstracts. But anyway.
Yeah.
Excellent point.
And it's organizational efforts like that to blind studies and blind ratings that contribute a lot to gender equality.
Okay, I will move on to number 50, last but not least. This is Ms. Roy. Once again, very well presented. Can you describe how the students were selected and identified to participate in the program? I'll start with that.
Yeah, so many electives are offered to all medical students at Pitt Med, and it's purely voluntary. They're not graded, and these were like Friday afternoons in January and February. So anyone who had the time could participate in this.
And then I think even, once again, the devil are in the details, particularly when dealing with the School of Medicine. What does the School of Medicine do regarding, do they receive academic credit, these medical students that take part in this program? Or is it just considered kind of on their free time?
It's not on our transcript as it's not graded, but there's a certificate of completion when students do complete it. And it really is purely for students' gain of knowledge. Like Pitt Med offers them in all different topics, not just surgical subspecialties, but also just different topics such as, learning more about EKGs or learning about new drug therapies or like medical interviewing skills. It can be in anything, so students can take them.
Do you think that there would be an uptick if they did honor them for academic credit?
Yes, I think if they were to be put on our transcript, there definitely would be an increase in students participating.
And logistically, who was doing the bulk of the teaching? Was it the residents? Was it the faculty? Was it other medical students that were a bit more senior?
It was a mix. Mainly the faculty would do the presentations, the lecture presentations for the first half of the session, and then residents would come help for the more hands-on simulation components and fellows as well.
You have additional questions, Dr. Kuzno?
No, I think the mini elective is a great idea. It certainly opens the idea of, or at least increases exposure to plastic surgery at a very early phase of medical school. The question I have for you, Eva, is do you think that you're going to shoot yourself in the foot in terms of now there's going to be such an increase in people wanting to apply into plastics that it's going to make it harder for you to match?
Thank you for the question, Dr. Gusinoff. I think it's good to have all these like first years and second years get good exposure, because what our study showed was that that I wasn't able to put in the presentation was a lot of the bias right now is through media exposure, family and friends, TV shows. So I think it's important that they at least have a solid foundation and knowledge of what plastic surgery entails. And then we plan to follow up to see what these first and second years actually apply into the future.
Very good.
Well, Jeff and Paris, thank you so much for moderating this last session and for all the presenters. This was an absolutely fantastic panel presentations. And I think with that, we're going to begin the process of wrapping up our 2 days of meetings at the Northeastern. I just wanted to make a couple quick comments before I turn it over to Brian. This has been a very interesting experience, this whole business of having to adapt to a completely different environment. And I think it shows the power of what we have in the plastic surgery community in the Northeast, that in a relatively short period of time, we were able to pull together a diverse program, have wonderful moderators put their time and effort into actually contributing their talents to the program, as well as an incredible diversity and talent within all the presentations. I want to encourage everyone to maintain engaged with the Northeastern, particularly with this this year's meeting by watching all the other virtual presentations that are still available and will be available on the website for another week and a half. Please rank them because there will be a prize for the winner of some incredible work that we weren't unfortunately able to present due to time constraints. I want to thank all the presenters and the moderators for their time, for their efforts, for PRI, Olivia, Stan, and Heather for all the work that they did to put this together. And I want to turn it over to Brian.
Great, thank you, Suhail. I couldn't have had a better program chair for this year. We've known each other for years, and you really rose to the occasion. There's a lot of uncertainty regarding this meeting and if it was going to happen at all. And this all did have to come together quite fast once we realized that an in-person option wasn't an option. But I want to thank all of you who are still on the line here for attending the Northeastern Society of Plastic Surgeons' first virtual meeting. Please, again, I'm going to say the same thing Suhail did about this. Please try to visit the virtual program portal. Again, as I said this morning, those presentations to us in any other year would have been up on the podium live being presented, but simply couldn't be due to time and space constraints, by nature of the program we had to put on here virtually. I want to thank all the abstract presenters, the moderators, the program chairs, the board of directors for all their support about this meeting, everyone at PRI, particularly again, Stan, Heather, Olivia, and particularly Suhail, our program chair, Suhail Control, did such an outstanding job putting this thing together and all the hours put in making this a success. I really hope to see all of you in March at the spring workshop, and I really hope to see you in person. You'll be receiving a lot of information about that, and we'll just have to make a call on virtual versus in person as time goes on and we see how the world progresses. And I particularly hope to see everybody next year in Philadelphia in person as well for our annual meeting, which was somehow miraculously, we managed to reschedule that for the same hotel in Philadelphia for next year. And of course, you'll all be receiving more information on that also. I've been honored, absolutely honored to preside over the last year, and I'm even more honored to have the opportunity to do it again. And I'm so excited to be able to plan the spring workshop again and another annual meeting with Suhail, and hopefully able to see all of you in person. So please be well. I hope you're all well and safe, and have a wonderful rest of your weekend. Thank you for attending this morning and this weekend.